Again,
is
I'm
there.
starting.
Uh,
A very good evening to one and all. I'm Dr. Bharani, and I'm honored to be the Master of Ceremonies for the day. And I welcome one and all to today's academic treat from Chennai Menopause Society, which will be on cardiovascular health and disease prevention around menopause. Um, So, as Mahatma Gandhi quoted, in the middle of difficulty lies opportunity. So, in the midst of all the challenges posed by menopausal transition, it is also the opportunity to proactively try and prevent the risks associated with cardiovascular disease. So, we will be listening from experts today about these preventive strategies and will be enlightening ourselves. We will begin with the prayer song and the virtual lamp lighting.
start off with Tamil Tal வாழ்த்து.
எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
I invite Dr. Rajalakshmi to now read the midlife prayer.
Good evening, everyone. We pray to God to give us grace to accept the midlife physical changes and gently renew our strength, guide our heart, our mind, and body to navigate the way, and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond moments of their life, and also for those sitting in a doctor's office or who are in bed asking for healing touch. On this day, may all the midlife and menopausal women have the gift of joy, hope, and good health. Thank you, God, for the promise of hope you hold out to all midlife and menopausal women and inspire us to give this gift of hope to others. Thank you.
Thank you. I request our President, Chennai Menopause Society, Shanti Gunasingh Ma'am, to give the welcome address. Ma'am is the current President, Chennai Menopause Society. She's a consultant in Mangalam Healthcare, Chennai, past President, Oxy.
Our chief guest is in another program too. So I think we'll oblige her by starting quite early. I have great pleasure in welcoming you all to the fifth webinar since we have taken over. All webinars so far have been power-packed, and it is really nice to have a webinar on the theme of this year, that is cardiovascular health. I'm very happy to invite Dr. Anju Soni, our chief guest, who's the president-elect Indian Menopause Society. And when she has a lot of credits and she's the chairperson of HIV/AIDS committee, and also the member India CCM, and Preston Jogs, and committee chairperson.
Thank you,
Lot of
Dr.
awards. Yeah.
Thank you,
And
Dr. Shanti, for your kind introduction. I think everybody knows me, so thank you for giving this kind introduction. And at the offset, I would like to congratulate you for organizing this beautiful, theme-based webinar today, because it really gives us the flavor which Indian Menopause Society has. We are all a multi-speciality group of society, so that flavor you have given to this webinar, which is so very important. And you just had such a huge problem in Chennai, and in spite of that, you have continued to do this program, which is really creditable. And I'm really very happy to see all of you here, and a dear friend, Dr. Revati, who has been a pillar for Indian Menopause Society, and your active secretary, Dr. Dr. Meera, and the chairperson, Dr. Muralidharan, and Dr. Gomti, along with the Professor Dr. Ganesh and Dr. Arun, who will be, focusing on the very important topic. And then you have very beautifully kept a panel, which will be, moderated by Dr. Meera, as Dr. TN as chairperson and expert, and again the experts. So you will be, I think, focusing very well on the very important topic, which we all know that because of menopause, when the estrogens are withdrawn, the cardioprotective effect goes away, and we need to really work on prevention, which is so very much important. So not delaying you further, I would like to thank you very much, and not come in between your academic feast. Thank you very much.
I would request you to read our Model 5, which is actually our e-newsletter, which is much welcomed and is power-packed actually.
Yeah, it's so beautiful, that you've come out with this beautiful, e-letter. And please share this letter with me. I would really like to go through it, because you have really put in so much of an effort, which is seen from, this beautiful effect. And you try and covered almost everything in this.
Yeah.
Congratulations to you for this e-letter.
Okay. Thank you very much. Dr. Anju Soni is a faculty elsewhere, so she was in a hurry. So thank you very much for being our chief guest and releasing our Model 5. We are really thankful to you. And I think I will also welcome our guest of honor, Dr. Revati Janakiram, President TNFOG, and who's really doing a lot of good work now there. And she's behind the massive school program, adolescent school program, which is done throughout the state. She's the founder secretary and past president, Madurai OG Society, founder president, IMS Madurai.
Okay, Shanti.
Yes.
All of
Yeah. And
Okay.
Madam, of course, is part of Chennai community. Half leg in Madurai and half leg in Chennai.
One leg.
Very happy to have you here, madam. And I also have to welcome all our chairpersons. I wanted everybody to be included. We have people from Kanjipuram, Dr. Angammal Muralidharan, who is really an active logician there. Dr. Gomati, who is HOD of Melmarvatur Adiparasakti Institute of Medical College. And we also have excellent speakers, Professor Amita Ganesh from AIMS Mangalagiri. I welcome you. I also welcome Dr. Arun Kalyana Sundaram, Director Cardiology, ProMed Hospital, Chennai. And of course, the other panelists, Dr. Subhashini, Dr. Rajeshri, and Dr. Sheila Nambiar. So it's really nice to welcome all of you all. Nice, excellent faculty. And I would request Madam to give her address.
Thank you. Thank you very much, Dr. Shanti, for your kind introduction. And actually, I'm part of Chennai. Right from the day I became the director of IUG, but all the more now as President TNFOG. And very present good evening to all. And thanks to CMS for inviting me to be part of this wonderful webinar on CVS and menopause, cardiovascular disease and menopause. You know, many a times women come to us during around the period of menopause transition for some problem or other. And it is very important that we as a gynecologist need to understand the risk factors for CVD and institute timely intervention. Now, see, around menopause, whoever comes to our clinic for any complaint, it's our duty to catch them up for cancer screening. Similarly, this also should be taken care of, like assessing the risk factors. Actually, menopause is a biological marker for CVD, and we have to educate our patients about the risk factors and try to correct them wherever it is possible. And it is quite unfortunate that we doctors, especially lady doctors, are not taking care of ourselves and not doing this assessment of risk factors properly. Say, for example, how many of us have done routine the lipid profile? You know very well that the lipid profile is equal to pap smear for cancer service screening. So that much of importance is there, but we have to take care of that also. And it's really good that you have chosen this topic of menopause and CVD, and you also brought in experts, eminent speakers, cardiologist Dr. Amita Ganesh and Dr. Arun Kalyanasundaram, who are going to discuss about the risk factors and as well as prevention, followed by the panel. I'm also very eager to listen to them, and I wish this webinar a grand success. Thank you very much.
Thank you, Madam. And I have to actually welcome Dr. Sai Meenakshi also from COPS Tambaram, as well as a very active member of IMA Tambaram. So it's really nice to have, we wanted Chennai to be, Chennai Menopause Society has representation from all these places. We want all of them to be actively involved in this program. Okay, thank you. Now over to Bharani.
Thank you, ma'am. So without further ado, let's move on to our first session. I'd like to welcome the chairpersons for this sessions. Dr. Angamal Muralidharan, ma'am, consultant from Kanchipuram. Madam is a consultant obstetrician and gynecologist for the past 18 years with a passion for preventive oncology, focusing on cervical cancer. Master trainer in HPV vaccination project, South Zone. We welcome you, ma'am. And Dr. Gomati. Madam is a professor and HOD in Melmaruvattur Adiparashakti Institute of Medical Science. She's a gold medalist, recipient of the Dhanvantri Award in 2008. She's done her diploma in gynae endoscopy and reproductive medicine with the field of interest, high-risk pregnancy and gynec endoscopy. Welcome you, ma'am. So the first talk for the day is cardiovascular health risks in women of menopausal age and screening by Dr. Amita Ganesh. He's the additional professor in HOD cardiology of AIMS Mangalagiri. He's has around 40 publications in national and international journals with special interest in clinical cardiology, preventive and rehabilitation cardiology, peripheral vascular intervention, and structural interventions. Over to you.
Hello, can you hear me?
Chairpersons also
Yes,
can.
sir.
Yeah, we can hear you, Dr. Ganesh.
Yeah. Happy evening all. At the outset, I would like to thank the Chennai Menopause Society, especially about to Dr. Meera Raghavan for inviting me to talk on this. After going through this topic only, I learned this is purely a clinical medicine, nothing to intervene in this. Shall I share my slide, please? 1 minute.
Yes, sir.
Sahiti, what happened?
Sorry for the delay. I'm just trying to share the screen now. It is taking time. 1 minute.
Yes, sir. You take your time.
Is it visible now?
No, sir.
Not yet, sir. Yeah.
Now it is.
Yeah.
Yes, it is.
Yeah.
Okay. Anyway, thank you once again for giving me this opportunity. Cardiovascular risk in perimenopausal women. Menopause is defined as a median age of natural menopause. Usually it's at the age of 50 years. I don't want to go into the details of what menopause is because you're all experts there. So the median age of menopause is 50 years, and premature menopause if it occurs before 40 years of age, and early menopause if it occurs between 40 to 45 years. And the definition of perimenopause, I realized that whenever the patient has symptoms of suggestive of menopause, it could be months before stopping the periods or weeks before. The perimenopause stage begins with the onset of intermenstrual irregularities or other menopause-related symptoms. This stage extends 12 months after menopause, and identified as a stage of vulnerability accompanied by significant alterations in severe cardiometabolic and vascular health problems, strongly linked to CVD risk. The thing I realized here is much before the actual onset of the stoppage of menstrual cycles, the symptom onset itself signifies that there is some problem going on in them, so which is very important to recognize. So, as Madam said, it is extremely important to recognize, to realize their symptom when they come to you for some symptoms during the premenopausal period. And everything which occurs during the perimenopausal stage is attributed to the estrogen deficiency, whichever is cardiac remodeling, endothelial function, BP, vascular reactivity, and immunity. One important factor in everything is the basis of every manifestation in the women is endothelial function, because of which the vascular reactivity is altered, cardiac remodeling occurs, because of which BP occurs, and then the same thing which continues as a functional manifestation in their mood also. So everything runs around the alteration in the endothelial function. Some facts about the CAD in perimenopausal women. Women develop CAD several years later than men, but there is a notable increase in the risk during midlife, during menopause. That's what every article which I read states the fact that when the patient starts having symptoms suggestive of menopause, either it could be a vasomotor symptoms or depression or any manifestation like sleep disorder, it could indicate already the CV factors, CV risk is starting in them. One particular importance in them in perimenopausal stage is type 2 MI, that's myocardial infarction, is very common. What is this type 2 MI? Type 2 MI really means these women need not have a obstructive CAD. For example, angiogram showing, usually we see people with the angiogram showing 90% stenosis. It may progress to complete 100%, so we go and do angioplasty. But in these perimenopausal women, they need not have an obstructive CAD at all. There could be a minor plaque of 20% or 30%. The important pathogenesis by which it causes MI is by plaque erosion. It's by erosion, not by actually plaque rupture. Again, another important quality in the difference in MI in these perimenopausal women is MINOCA. MINOCA is myocardial infarction with no obstructive coronary arteries. So these types of MI really highlights how important is for us to understand the real pathogenesis of myocardial infarction in these patients. Many of these patients after MI, when they come to us, we do angiogram. Angiogram shows minimal coronary disease or no significant disease. We send them on medical management and they usually lost follow-up. Again, to prevent recurrence, follow-up is very important. As Madam said, addressing the risk factors is very important. Up to 30% of these perimenopausal women can have spontaneous coronary artery dissection. So the etiology, the etiopathogenesis of myocardial infarction caused in these perimenopausal women is entirely different from what is usually happens in patients with the multiple risk factors, what we call obstructive CAD. So obstructive CAD is very uncommon in them. Again, signifies the fact that we need to be more aggressive in preventing the recurrence in these patients. And then coronary vascular dysfunction, which I told you before, the vasospasm or microvascular disease much more common. This sort of pathology is very difficult to treat because unless we understand the pathology in them, very difficult to treat in these patients. Again, gender differences in coping up with stress. This is the cause of one of the main cause of coronary vascular dysfunction and menopause. Again, the estrogen deficiency causes functional manifestation by altering their stress manifestations also. One important point I want to make is this so-called Takotsubo cardiomyopathy, which usually happens after 55 years. It is actually not related to estradiol. It actually relates to a difference in the stress coping up strategies between women during perimenopausal stage. So there are two components when we see factors which are responsible for their cardiovascular risk. One is the estrogen deficiency causing vascular dysfunction. Second is the functional manifestations. So what are the menopause characteristics relevant to CVD risk? There are so many studies done. One of the most important studies is SWAN study. They have extensively studied so many factors in them. Very interesting to see that. So there are actually 5 factors which relevant to the CVD risk. One, age at menopause, type of menopause, menopause stages, endogenous estradiol, and menopause related symptoms. So each factor has some risk associated with the cardiovascular pathologies. One, any menopause less than 45 years, it increases the overall fatal CAD and heart failure. Women attaining menopause between 50 to 54 years has reduced risk. So any patient who attain natural menopause less than 45 years, they need to be on close follow-up for any symptom suggestive of CAD. Many of them, they present spontaneously. I don't know, the past 3-4 years, I have come across at least 1 cases per week without proper risk factors around perimenopausal stage. They come with spontaneous MI. The history states like that. Till the day back, they were normal. Suddenly, they get all the symptoms. Sometimes they have very severe LV dysfunction where we could not do anything. So assessing these factors are very important. And then type of menopause, bilateral salpingo-oophorectomy with no estrogen obviously carries the increased risk of CHD. Hysterectomy without BSO is not associated with increased CVD risk, and no association is if the BSO performed around natural menopause. If the BSO is less than 40 to 45 years, again, there is substantially high risk than with BSO with no estrogen. Then menopausal stages. As I understand, menopausal stages are classified into premenopause, early and late menopause transition, early and late post-menopause. These are stages classified. But why it is important to understand these stages? Because symptoms promptly progresses in each stage. And when we know which stage, which changes occur, we can promptly intervene these issues. There is an increase in systolic and diastolic BP is noted in the late menopausal transition. Increase in total cholesterol, HDL, LDL, and lipoprotein A noted in late menopausal transition and early postmenopause. Here I have 2 things to say. I have specifically mentioned this HDL in red because after menopause, during perimenopausal stages, HDL also increase in contrast to other cardiovascular risk factors. See, we expect when increase in HDL brings down the CV risk. Usually that's what the teaching is. When you have increased levels of HDL, your chances of CV events are less. But in perimenopausal women, peculiarly, in spite of associated increase in HDL, they have increased events. The reason behind this is that HDL is a scavenger. They clear cholesterol from periphery. In patients with the perimenopausal stages, these HDL are qualitatively deficient. So when a patient comes to you, you do a lipid profile and the HDL is more, you cannot be happier because these HDL are altered HDL. And then this lipoprotein little a, which is more specific for South Indian women, increases the risk of cardiovascular events for which we don't have much drugs to give for. And then vascular changes that occurs, for example, carotid intima media thickness, which also occurs in late menopause. So the take-home message in this slide is that though there is an increase in HDL accompanied by a perimenopausal transition, it is not a good HDL, it is useless HDL. And then increase in lipoprotein little a, especially in South Indian women, predisposes to atherosclerosis. Endogenous estrogen, as I understand, the actual levels of endogenous estrogen may not correlate with their actual stage of the menopause. Sometimes even in the premenopausal stages, the endogenous estrogen may be less. So actually declining estrogens during menopausal transition, it alters the CVD risk. Suppose there are two patients in the different periods of menopausal transition, but one patient with less endogenous estradiol, they'll have more risk actually. So they actually cause vascular remodeling. This is most important, which I like the most actually, menopause-related symptoms which are often under-recognized because any women around the age of 40, 45 to 50, they will have a lot of family problems. When they come to us with a lot of atypical chest pain or vasomotor symptoms, we tend to ignore them and we are ignorant because many of us, we don't realize that these symptoms are due to menopause, which again signifies the onset of cardiovascular risk. Three important symptoms which are very, very important is vasomotor symptoms, sleep disturbances, depression. So all these symptoms indicates that already internal changes are going on, atherosclerotic changes are going on, vascular changes are going on in them. They may have menstrual periods, but with these symptoms, sometimes vasomotor symptoms can be there even 12 months before the onset of actual menopause. So it is important, as Madam said, we have to listen to their symptoms to assess their risk. The timing and frequency of vasomotor symptoms vary over the menopausal transition with the 4 patterns described. Only is early onset symptoms, 11 years before the actually LMP. Another is onset near the LMP and persistingly high frequency and persistently low frequency. Suppose you have 2 women in the same perimenopausal stage with the low frequency of vasomotor symptoms, they have low risk of developing cardiovascular events because these vasomotor symptoms signifies vascular remodeling, abnormal endothelial function and functional problems also. So vasomotor symptoms in midlife associated with altered lipid profile, as I told you, once the vasomotor symptom starts, there is a vascular remodeling, cardiac remodeling. So it alters the lipid profile, increases the insulin resistance, increased hypertension risk, decreased flow mediated dilatation. This concept is very important because this property of increasing the dilatation of the vessel because of the flow is a function of endothelium. So wherever there is an increased flow, the vessels have to dilate. If it doesn't dilate, then it's a problem. So this property gets abolished when the patient starts developing these vasomotor symptoms. Then aortic calcification, which is actually a paradox. Women with vasomotor symptoms early in the menopause transition with the more frequency, as I told you, they have already shown increased carotid intimal media thickness, and they carry increased risk of CAD and CVA independent of other factors. So the vasomotor symptoms in the perimenopausal stage is as important as anything. It's one of the very good clinical indicator for the fact that they are going on with vascular changes. Again, sleep disturbances. One of the very common symptoms people come to any physician, insomnia, for which every one of us rate tablet Alprax or Zolfrex, send them off. But at least after going through IBLM sessions, I am very clear now, people who are with poorer sleep quality, especially during menopausal transition, they are at greater risk of metabolic syndrome, increased carotid plaque and CMT, and aortic calcification. This is very, very important. This aortic calcification is an independent association. Whenever you diagnose this, already they have established risk for cardiovascular disease. So we have to listen to their sleep disturbances also. And then depression. Again, many of these patients, when they come with some altered, because of the family problems, they come with some manifestation, we ignore that. Because depression is again an independent risk factor for women who has these depressive symptoms. And more than 3 episodes in 5 years found to have increased coronary calcium score. And we all know increased coronary calcium score predisposes to cardiovascular events much earlier than anybody else. So 3 important changes which are very important: vasomotor symptoms, sleep disturbances, and depression. These 3 important symptoms, when the patient has these symptoms, they are again already in the stage of CV risk. So cardiometabolic changes beyond the chronological aging, which cannot be explained only with the aging, lipid alteration in the lipids, blood pressure, insulin, glucose, metabolic syndrome, vascular remodeling, weight gain, body composition, and ectopic fat. These are the studies which they quote for these references. These are the changes which noted. Total cholesterol, LDL, ApoB increases dramatically from the year before to the year after the menopausal stage. Out of these ApoB is very important, very less studied about it. ApoB, the levels of ApoB, apolipoprotein B, actually indicates atherogenic proteins. When ApoB is increased, irrespective of your HDL, irrespective of LDL, your chances of increase in atherosclerosis is very high. So ApoB levels should be a part of our lipid profile evaluation also. Again, as I told you, HDL undergoes qualitative changes. Reversal in the direction of association is noted. It's very, very important concept which I understood now. Before menopause, we know increased HDL, protective. After menopause, increased HDL is not protective because the HDL the quality of HDL is increased. So normal levels of HDL after menopause need not be normal. This is a very important point to understand. And the increased prevalence of metabolic syndrome, again, is especially in postmenopausal, which cannot be explained only by the age. And then all the vascular changes, weight gain occur, which is not purely explained only by the chronological age, actually. So how do we screen? As I understand, the first point in screening is proper assessment of symptoms. Again, in various processes, it is stressed. These symptoms are being stressed in every textbook we go through. Vasomotor symptoms, sleep and mood disorders, we have to listen to them and we have to take a proper steps in identification of underlying cardiovascular risk in these people. And then many of these patients which I have seen during the perimenopause, they all have masked hypertension. So what is this masked hypertension? When you measure the BP in your clinic, it could be 130/80 or 136/80 or still less than that. But when you start doing echo in them, they have left ventricular hypertrophy in echo, which means that they have already manifested the end organ damage in them, which means that their BP is fluctuating throughout the day. So how do we understand this? We do what is called ambulatory BP. Now, this ambulatory BP is given much importance in these women because their BP will be fluctuating in the night because of increased sympathetic flow, increased cortisol level, which again predisposes to all vascular events in the night. Because for all of us, there should be a dipping in the BP at night, which doesn't happen for them. In fact, it increases in some of them, predisposing to other vascular events. Again, to include the assessment of vitamin D and B12 levels, ApoB, as I told you, in addition to all your routine blood investigations. Again, appropriate use of cardiac investigations for stratification. One of the most misused investigation, I would say, is TMT, because TMT has its own specificity and sensitivity. If somebody's TMT is positive, doesn't mean that they have coronary artery disease. If it is negative, doesn't mean that they don't have disease. So when we ask for a TMT, I know what I'm asking for. If I ask for effort tolerance, I don't interpret the changes. So what I would suggest is, before ordering a TMT, I would be very, very careful why I order a TMT. Because once the TMT somebody reports as positive and we end up in doing angiogram shows no significant disease and the patient continues to have chest pain because doctor TMT positive, so he'll be getting dual antiplatelet, statins, beta blockers, multivitamins, which is not at all necessary. So again, the patient will come and say next year, sir, please do another TMT. I try explaining them, TMT will not become negative in you, don't worry. It is not ischemic, it is false positive, and they won't listen. Their life got ruined. So before ordering a TMT, that too in a perimenopausal woman, false positives and false negatives are very common. I think 100 times before I order TMT in them. And even if I order TMT, I know what I want to look for. Again, important investigation in them is coronary calcium. Again, as I told you, coronary calcium takes very 3 seconds or 4 seconds, which will predict increased risk or no risk in them, so that we can initiate primary prevention in these patients. If at all you want to do inducible ischemia, I would prefer to do a stress NPA, because rather than TMT, in many patients where the TMT is false positive, the stress NPA, myocardial perfusion imaging, either by MRI or by nuclear scanning, if it is negative, at least the prevalence will be very less in them. Very, very rarely, I advise them to do either coronary angiogram or CT-CAG. As it is mentioned in many places, CT-CAG should not be done as a part of screening. And then in the American Heart Association, they have developed a Life Simple 7 score, taken into account of 7 factors in them. For example, high BP, cholesterol, sugars, physical activity, obesity, everything. And they give a score to classify them into ideal, intermediate, and poor, which may not be applicable in India. And then use of risk scores for assessment of may also be done, Framingham risk score and ASVD score. And while application of this score, we should be very, very careful in classifying these patients into low, intermediate, and high. Everywhere, whatever you assess in them, the lifestyle modification is very, very important in these patients. So lifestyle modification is the key, concentrating on all the other pillars, all the 6 pillars like diet, physical activity, restorative sleep, stress reduction, and social connections. I try to address each and everything in these patients to many extent, actually. I don't want to go into the details of all these things of management. One important trial which showed that the Pittsburgh WHLP, Women's Health Lifestyle Project, where they randomized around 500 patients to intensive lifestyle modification, which included hypocaloric diet with the reduced saturated fat and cholesterol combined with exercise. Definitely, there is an LDL increase in these control group when compared to the other group is blunted in the intervention group, which is proved beyond doubt that in lifestyle modification helps in preventing many CV risk in these people. Similarly, the intervention group had less weight gain, and they had a less triglycerides, they had less systolic BP and diastolic BP, their blood glucose levels were well controlled. And then the hormonal therapy did not modify the association. So you can ask me if the patient has menopause and they have given MHT, it did not modify. So purely a lifestyle modification helps in alleviating the or reducing the risk of future CV events. So again, as I told you, HRT is not very useful. Periodic monitoring is very important in these people to avoid any future events. Just a word about milk, because it is again will be discussed in the panel. There are 2 different school of thoughts regarding milk consumption and osteoporosis in these women. I just quote 2 reviews. This is a very big review from so many countries around, systematic review. So with so many studies around the world, despite an inverse association between milk and dairy intake and risk of osteoporosis and hip fracture in cross-sectional and case control studies, no such association was seen in cohort studies. Given the advantages of cohort over case control, these study concluded that a greater intake of milk and dairy products was not associated with lower risk of osteoporosis. This is one study, which is cohort, and one more. Many things are quoted in that. I don't want to go into the details. There are studies, pros and cons in that. So only thing is I want to highlight is, while continuing on lifestyle modification, we need to advise them on what are the diets, everything in them, and accordingly we need to advise them. That's all. Thank you so much for your patient listening.
Thank you so much, sir. I request our chairpersons to give their valuable comments.
Good evening, sir. I'm Dr. Angamal.
Yes, madam.
Thank you for a very wonderful, clinically relevant, and in-depth elaboration of all the cardiovascular health risks in women of menopausal age, sir.
Thank you.
Sir, actually, we are very much indebted to for enlightening us on all these aspects, like how the women's MI pathogenesis is differing from the routine men, and the level of impact of stress. And also, you highlighted about the under-recognized signals, particularly the VMS, sleep disturbances, and depression as the risk factors of CVD. And also, you are highlighting about the screening investigations, and your cautioning point about the TMT is very, very practical point, sir. Thank you, sir, once again.
Thank you, ma'am. Thank you. One more point I want to add regarding the stress, because I am facing a lot of females who have urinary incontinence. Whenever I talk to Meera madam, I used to tell this. Many females around the perimenopausal age, they are distressed with their urinary incontinence. So that is one big factor I feel I have screened as far as I have seen. So because so many urogynecologists are there to address that, actually one of the major depressing factors for them.
Yes, sir. Very definitely, it is a lifetime the thing, sir.
Can,
Can we have, if we're done with the comments, I think we can move on to the next talk. If there are any questions from the participants, please leave them in the QA box. The experts will take your questions in the end. We'll go on to the next talk, prevention of cardiovascular illness, risk mitigation, primordial, primary, and secondary prevention in menopausal women. I request our chairpersons to introduce the speaker, Dr. Arun Kalyanasundaram.
I'm honored to welcome Dr. Arun Kalyanasundaram, sir. He's an American board certified in cardiovascular medicine and interventional cardiology. He's director ProMed Hospital, Chennai, India, and he's a director CTO program from USA. He also is Asia Pacific chronic total occlusion director, founder director in CTO India. I welcoming you, sir. Over to you, sir, for your enlightening talk on your topic. Thank you, sir.
Good evening. I'd like to thank Dr. Meera Raghavan and everyone else in the Chennai Menopausal Society for the opportunity for me to talk today in this August forum. So just to kind of set the record straight, I'm basically an interventional cardiologist. I open up I do a lot of complex angioplasties. That being said, I have a pretty strong interest in prevention. That's how I know Amrita Ganesh and Dr. Meera Raghavan and a lot of the other people. So it's truly honored to be here. I saw the initial, interaction amongst all of you. It was really heartening to see that. So without further ado, let me kind of cut to the chase. Interestingly, I think, although Dr. Meera Raghavan did her best in trying to divide the talk between Dr. Ganesh and I think there's some overlap, but you might get a slightly different flavor. So again, I will try to focus just on the relevant stuff. I think you guys can see my slides. So I'm just gonna see. Okay, good. So I kind of thought, let's go through the whole panel, right? You guys are some of the leaders in OBGYN. You see patients across you're almost like the PCP for a lot of women. And why do we focus on women? Initially way back, and I think the prevailing myth was women are not really that different than men. They're just smaller people. So why do we have to worry about it? Do we have to do anything different? They were underrepresented in registries, clinical trials, and pretty much what applies to men also applies to women, was kind of the dictum. But if you really think about it, people need to realize that heart disease is the leading cause of death in women. This is globally and in India. So there's a lot more women die of heart disease than even men. 1 in 3 has some kind of cardiovascular disease. And, there are significant biases globally, and I would say in India in particular, when it comes to testing and treating women. The bulk of it goes to coronary artery disease, which is blockage in one of the major blood vessels supplying blood to the heart. And coronary artery disease, of course, can lead to heart failure, and there could be problems in other blood vessels too. So the whole cardiovascular area represents a significant amount of heart disease in women. The other problem is this dogma that people, I mean, there's this perception that, oh, women don't get heart disease, right? Women are supposed to get cancer. There's a lot of awareness about, a lot of other health conditions. Very few people kind of perceive heart disease as something that affects women, right? And although it's the number one killer, this perception is not just true in America, but I think it's true globally, not just in India. Again, leading cause of death, kills more people than all the cancers put together, pretty much globally. And if you look at it, even across populations, right? I mean, yeah, when you're younger, you probably get away. Like, estrogen is pretty protective. But as people get older, women get as much, if not more, CAD than men. And obviously, there's a selection bias here because women generally tend to live longer. So there are more people there. Now, I'm going to just also have you focus on this, right? We talk about there are certain gender factors, the psychological part, the social part, cultural, behavioral, and of course, the actual sexual part, which is, the anatomic, the physiologic, the genetic, and the sex hormones, all of which contribute to cardiovascular disease. Now, I think Dr. Ganesh beautifully talked about some of the preventative stuff, etc. But the key thing is to use you guys see women way before people like me or Ganesh do. And so there's a very, very important focus should be on, the primordial and the primary prevention. So I think early on, women almost always will see you for their OB needs, right? When they're pregnant, etc. So use it as a chance for your risk assessment, make sure they're aware of these problems. Start early on in terms of the lifestyle modification. I also have a couple of slides on Life 7, etc. So without belaboring the point, I'll kind of just briefly touch upon it. But that's a teaching moment for you guys. And likewise, for women with coronary artery disease, you still want to be super aggressive about how you prevent further events, the so-called secondary prevention, right? And of course, we want to prevent complications of coronary artery disease. And we also want to ensure that they get appropriate therapies when needed. Now, why is this thing about middle age? What's so magical about it? Again, just to reiterate some of the points, so this was a really busy slide that I saw. I'm like, oh my God, I'm so happy I'm not an OBGYN doctor because I can't keep all this straight. But long story short, women go through a lot of hormonal changes during their time. And this whole the menopausal transition time is one where a lot of the hormones that were protective kind of go down, and then subsequently they really catch up super fast with men in terms of all their cardiovascular risk factors. Now, of course, that busy slide was just to illustrate that I really appreciate what you guys do for women. But the point I want to emphasize is that menopause, this is really interesting. People with early onset menopause, that's an independent risk factor for coronary artery disease. So that's something that I want you guys to remember. If you have someone, and I'm sure you might know this, but I just thought I should kind of emphasize that for those that might not be aware. So if you have early onset menopause, make sure that, hey, that's a red flag for CAD. All right. I think Amrita already talked about some of the vasomotor symptoms. Now, that is linked to worsening lipid profile, insulin resistance, and hypertension. Likewise, people complain of the hot flashes and sleep disturbance. Now, just remember that both of that it will put you at a higher risk for the metabolic syndrome, as well as your carotid atherosclerosis and CAD. Now, the other thing I think, again, was kind of discussed, depression. All the hormonal changes and whatever is going on in their lives at that point, sometimes just like postpartum depression, people can go through depression during the menopausal transition. And that's an independent risk factor again for coronary artery disease. And it's kind of a catch-22 because CAD also has a correlation with depression. People who have coronary artery disease can get depressed. Depression can make CAD, puts you at a higher risk for CAD. Now, this was kind of an interesting thing. Like, some of the studies that are out there have shown that there are certain relative contributions just by virtue of aging. As we get older, we are more likely to have coronary artery disease. And the reproductive aging, or these hormonal, the whole change, the seismic events that are happening in the body, also contribute to a much faster risk, higher risk for cardiometabolic health. So some of it has shown that there are certain risk factors that are more because of this changing hormones, and some of them is just by virtue of them getting older. Honestly, to me, this is like splitting hairs. It doesn't matter. The point is, around the menopausal transition time, people are at higher risk. Okay. So we really need to be more cognizant, more aware, and more in tune to like screening them, taking care of their needs, addressing all the risk factors at all the levels. Now, so remember, the vascular health is there are multiple ways to test it, right? So I'm not saying that everyone needs to get carotid intimal medial thickness, or you need to screen, basically screen people for this, etc. But the point I want you to remember is that it's not just about the heart; it's about your vascular territory in a plethora of vessels. So just be mindful of that, and just know that women are at higher risk for a lot of cardiovascular diseases, and I'll kind of talk about that shortly. Now, again, people often have weight gain at this time. They tend to get less active. This can be because of chronological age, but again, this puts you at a higher risk for CAD. Now, primordial prevention, right, which is basically saying like, hey, we're going to take out this problem even before they get any of the risk factors. And what are the risk factors? We'll talk about that in a little bit. But you're trying to address this problem at the root level. So there's going to be significant overlap between what we recommend for primordial prevention and primary prevention, because for primary prevention, you're addressing the risk factors, but a lot of the lifestyle stuff that you do as primordial prevention will also have a very telling effect on primary prevention. Now, this basically will ensure that your patient has a lower cardiovascular risk and thereby reduce their chance of coronary artery disease. Now, the more lifestyle factors that you have, this is from the Women's Health Initiative, the better off you are going to be. So if you have no good lifestyle factors, you're at a much higher risk. And if you have more optimal lifestyle factors, the less likely you are to have heart disease. So let's just look at what they are. In this particular study, what they showed was, for your clinical CVD risk factors, which is really primordial prevention, you're talking about, and you can kind of see how the hazard ratio plays out. But essentially, more TV watching, not good. Smoking, not good. Alcohol, not good. Poor diet, not good. Less physical activity, not good. And increased BMI is not good. If you have everything, you're much worse. And all of these, interestingly, other than TV watching, has a unfavorable hazard ratio when it comes to coronary artery disease too. Now, what are the risk factors that you're talking about? Age, can't do much about it. Menopause, really, again, it's there are certain lifestyle factors that can contribute to your age, but a lot of it might be genetic too. And you guys are OBGYN, so I did not really want to spend too much time on that. The traditional cardiovascular risk factors, your high cholesterol, your diabetes, tobacco abuse, which fortunately in India is not that rampant, although it is kind of going up, and even amongst women, hypertension and obesity. Now, there are certain factors that just put you at a higher risk for CAD, chronic inflammatory conditions. We talked about premature menopause, adverse pregnancy outcomes, having a family history of premature coronary artery disease, which is defined as for women less than 65 in a first degree relative, or a man less than 55. Just being us, South Asians, puts you at a higher risk. Cholesterol, kidney disease, metabolic syndrome, a high CRP, lipoprotein A greater than 50, ApoB greater than 130, and of course, having peripheral arterial disease. Okay, the Life 7, which is really focusing on what can you do about a lot of these. What can we do? We can watch our BMI, make sure we don't get obese, so stay active, eat healthy, right? So I think 2 and 4 are really related to 1. Avoid sedentary behavior, walk around, make sure sitting is the new smoking was kind of a cliche that came out a few years ago, but although I don't know if it's as bad as smoking, you definitely want to keep active. And I think for those minority that do smoke in India, please avoid it. Of course, make sure your cholesterol is under good control, your blood pressure is under good control, and your fasting glucose, that you're not even getting into the pre-diabetic zone. And interestingly, even the traditional cardiovascular risk factors, the diabetes, hypertension, and obesity, affect women much worse than they affect men. This is kind of interesting, right? So diabetes puts you at a much higher risk for cardiovascular mortality than in a man if you're a woman. There's an increased risk of heart failure. There's worsening microvascular dysfunction, the so-called MINOCA, etc., where you have normal coronaries, but you still have disease, you have pain, you have angina. Hypertension, again, leads to worsening cardiovascular mortality compared to men and women. And women are less likely to be treated to goal. Obesity, there's a higher prevalence. And again, that makes it an independent risk factor for coronary artery disease in women compared to men. This is a busy slide. But again, I just put it out there so that you guys can just get a bird's eye view on what are all the things that could contribute to it. I think I've touched upon most of these: the smoking, hypertension, cholesterol, obesity, especially the truncal obesity, right, that we see around the belly region, bad diet, physical activity. Dr. Amrita has already talked about what are some of the meaningful dietary changes that you can do, and we can kind of talk about that later, I think probably in the panel discussion. Can't do much about family history. Metabolic syndrome, truly, I think, is lifestyle mediated disease. Work on it. Be pretty aggressive about screening for advanced subclinical atherosclerosis, for people, and again, work in conjunction with someone. I do appreciate us not testing indiscriminately without knowing the ramifications, whether it's a treadmill test, whether it's a nuke scan, whether it's a cardiac CT or whatever you choose to do, because there are downstream sequelae for that. But again, in the right setting, I think we should also not be shy of screening people when appropriate. Interestingly, having a poor work capacity on treadmill or a 6-minute walk test does have an adverse outcome. Other systemic collagen vascular diseases, etc. These are all risk factors for coronary artery disease. So what can we do about this? If you're a smoker, don't smoke. Weight loss, eat healthy, and DASH diet is just one for hypertension. In fact, there was a recent ranking by American Heart Association about the various diets. Now, arguably, whether it's the Mediterranean diet, whether it's a whole food plant-based diet, it's a DASH diet, I think the big picture is less processed, more plant-based, less oily, less salt. Make sure your plate is colorful, get enough vegetables, fruits, and whole grains. I think that would be like the overarching theme in a lot of these, and have your nutrition from a wide source. Physical activity, definitely keep moving, and ensure that these silent risk factors, the cholesterol, blood glucose, and your blood pressure, are optimally controlled. And these pretty much put you at a high risk state. We're not even calling them risk factors anymore. When you actually have overt coronary artery disease, when you have cerebrovascular disease, when you have peripheral arterial disease, when you have a AAA, when you're on end-stage renal disease, you have diabetes, or your 10-year predicted CAD risk on one of the scores is greater than 10%. What is ideal? This slide is kind of self-explanatory. Good cholesterol, good blood pressure, good glucose, all the opposite of everything that I just said, all right? And so that really should be the goal. And for physical activity, if you do want a metric, aim for at least 150 minutes per week. That's like almost 30 minutes for 5 days and of the 7 days of moderate intensity. Just taking a leisurely stroll is still good, but that's not considered moderate intensity. Make sure you move. And again, HRT, a lot, there's a lot of bad press after like the original trial that came out. I mean, you guys are experts in this. Again, should be done with caution, not purely with the aim of reducing cardiovascular risk, although I think the story is not yet over. What are some of the non-estrogen based pharmacological therapies that we can do? Statins, I still would say, is the mainstay when it comes to addressing cholesterol issues. If you have high cholesterol, your first line is probably still a statin. PCSK9 inhibitors and fibrates also have a role. And now we have some newer kids in the block, but I would say the mainstay is still statins. Aspirin, we've kind of gone back and forth as cardiologists. Initially, it was all about high dose aspirin, the 2, 3, 25, etc. Then it was about there's no big evidence in high dose compared to low dose. In fact, pretty much nobody should be on high dose, which is anything defined more than 100 milligrams per day. And in certain patients, in women, it is useful, but there's insufficient evidence to recommend routine low dose aspirin for primary prevention. Although it might have some beneficial effect in strokes. Antihypertensives, against dealer's choice, just make sure we know hypertension is bad. Start with the lifestyle modification, but if it doesn't work or if it's not enough, have a low threshold for pharmacotherapy so that you can get them under optimal control. Same story with diabetes. You got to be pretty aggressive about how you manage this. So I think, the era, or at least, for me, one of the things that I see that's very unique in India is like people often go to the specialist and only see the specialist. So I think a multi-pronged strategy works very well. I mean, I refuse to see patients unless they have a primary care doctor, because as an interventional cardiologist, although I can do this, one, it takes too much of my time, and I'm not keeping up with all the latest guidelines and all the risk factor modification and all the age appropriate screening. So I think multi-pronged, having this multidisciplinary approach really, really helps. And of course, do everything you can to prevent metabolic syndrome, right? I mean, that's just bad. And I think if we did a lot of what we were talking about, this will reduce the chance of having metabolic syndrome. Now, I also want to focus a little bit on gender differences. Now, remember, women actually get strokes, and more women die of stroke than men. And stroke is something that I think is oftentimes ignored. And it's interestingly more women get stroke than men, and it kind of flips less than 75 years old when you're talking about coronary artery disease, men and women. What makes them more at risk? One is perhaps, just going through the whole pregnancy, maybe, some of this hormonal whole cycle of changes that they go through, etc. And also, as they live longer, more AFib, which puts you at an independent higher risk for ischemic stroke. And also, higher prevalence. This is a very interesting slide. You can take it as a cup half full or cup half empty. There are more avoidable risk factors in women compared to men, which means you also have the opportunity to make more of a difference in women than in men. Because you can do something about physical inactivity, you can do something about obesity, the cholesterol, etc. And for diabetes, treat it even more aggressively, because it just puts you at a much higher risk factor for heart disease than men. So now the irony is that women are less counseled about nutrition, exercise, weight control, etc., compared to men. This is a global phenomenon. And so while this is true, I think it also provides us an opportunity whereby we can make a meaningful impact on reducing bad outcomes. And again, I think Amrita kind of talked about it, but the point is, like, women tend to have CAD at a later age. Many times they have no antecedent symptoms. Now, just remember, they almost go to a 3x compared to before menopause, post-menopause. They're more often admitted with unstable angina, or like just worsening sudden onset of chest pain or heart failure. And women, can, if you look at this number should actually be very scary, right? A quarter of the patients who have had an MI die within a year. And this number hasn't changed much over the last decade. Now, women also have atypical symptoms. I do want you guys to be aware of this, because you see a lot more women than we do generally. They don't always have the classic symptoms of crushing chest pain going, like it's not like in the movies where they just clench their chest and say, oh my God, this is disabling symptoms. Women often have atypical symptoms. They could just feel really fatigued. They could just be weak. They could have more shortness of breath, sometimes palpitations, back pain, just don't feel right, indigestion, etc. Oftentimes people ask me, Doc, is there a way? I mean, unfortunately, thanks to social media, you get questions like, can I please tell me how to distinguish between indigestion and heart attacks or chest pain from arising due to angina? The honest answer is you can't. And it's because, you know, even a cardiologist could miss it. That's why we have more testing. And for women, it gets even harder because many times the symptoms are not typical. They have higher rate of early death after MI, higher rates of in-hospital mortality. They are offered angioplasty and stenting less often than men, you know, in almost higher rates of heart failure. And I already talked about unstable angina. So women are, you know, undertreated, their outcomes are worse, they're offered the therapy less, their risk factors are often, you know, it's more modifiable, and they're also more atypical symptoms. And again, if you look at the gender differences, look at the number of women with no follow-up compared to men, right? So it's just like a more underserved population, literally, and that's just not okay. Now, you know, this is a busy slide, but the long story is that yes, women are really ignored. You know, just to summarize, I've talked a lot about this. I think Amrita stressed on the first point, so I'll skip that. A lot of people are going to be postmenopausal. So this is not a problem that's going to go away. As the longevity increases, you're going to deal with older and older people. So let's learn how to take care of them better. I already told you early age of menopause is an independent risk factor. Now, vasomotor symptoms correlate with coronary artery disease risk factors. Sleep disturbance matters. So my point is, as they go through menopause, address these symptoms, try and, you know, work with them through all of this. Depression, independent risk factor for CAD. The visceral fat correlates with coronary artery disease. On echo, or on CT, if their pericardial fat volumes again are higher after menopause. And just going to say this, their risk factors like increase in lipids, etc., everything gets worse after menopause and is almost accelerated. I want you to focus your attention on the third point. Very few people are at target. Less than 10% who are going through menopause have enough physical activity, and less than 20% actually eat a healthy diet. The nice thing again is a lot of the risk factors are modified. So a multi-dimensional lifestyle intervention can prevent weight gain, have a very favorable, you know, outcome on your risk factors, your blood pressure, your blood glucose, your cholesterol, your fasting insulin, your subclinical atherosclerosis, etc. And all of these will lead to less cardiovascular outcomes. So just remember that this menopause transition is a period of accelerated cardiovascular risk. So be vigilant, look for symptoms, ask these screening questions, and you know, work with the patients. Again, I'm not going to talk about hormonal therapy here, but the point is for those people that, you know, do need it, early initiation, less than 60 years of age, or within 10 years of menopause, maybe there's a tendency for reduced CVD risk, but I think we need more data out there before we go out and recommend this. Interestingly, women-specific evidence-based data is limited still, but if you look at the overall data from population, I think, you know, treating your cardiovascular risk factors does have a very favorable outcome long-term. Now, finally, here's what I want to say, right? I mean, you know, make sure you do all the screening, you know, your full exams, your risk assessments, etc. for, you know, if they have no antecedent risk factors or you know, coronary artery disease. And then for people, you know, everyone should get, you know, healthy diet, physical activity, weight management, smoking cessation. Now, if patients do have a higher risk of CAD or have, you know, established CAD as one of those I told you high risk states, then put them in cardiac rehab, make sure they're evaluated properly, etc. Ensure that you really treat all their risk factors to go aggressively. And, you know, of course, make sure as the population ages that you do screen for atrial fibrillation. And, you know, because not treating women with AFib puts them at a higher risk for stroke, and women do get more stroke. It all comes down to healthy lifestyle, addressing your basic risk factors, being cognizant that the symptoms are often atypical, ensuring that you work as a multidisciplinary team and getting them on board as needed. And with that, I thank you very much.
Much. comments.
Thank you, sir, for taking prevention is better than cure. Thank you for taking us through various levels of prevention in these menopausal women so that their cardiovascular risk factors are mitigated. So we should consider this menopause as a critical window of opportunity to assess the risk factors, instill the preventive measures, thereby protecting them from this deadly disease. And obviously, the prime life of menopausal women will be preserved. Thank you, sir.
Thank you very much for those, I think, remarks. Do we go into the panel discussion after this? I forget. Is that what happens?
Yeah, in we just have a quiz for our participants before we go to the panel discussion. Can I ask Sahiti to open the poll for the
Yes, ma'am.
participants
Sure,
to
ma'am.
answer?
Sure, ma'am.
Yeah.
We'll finish off quickly, sir, the quiz for participants.
Okay. First question.
Participants are attending the quiz, attempting the quiz rather.
Last 5 seconds. Time up. Second question. Time up. Third question. Last 5 seconds. Time up. Fourth question. Last 5 seconds. Time up. Fifth question. Last 5 seconds. Time up. Thank you.
Uh,
Yes, ma'am, all the questions were over.
Okay.
We're done with the quiz. Ma'am, we'll go to the panel discussion, ma'am, and we'll discuss the answers for the quiz in the end. I request our chairperson for the panel discussion, Dr. Sai Meenakshi, ma'am, to take over. Can we have Sai Meenakshi,
Yes,
ma'am,
ma'am.
CV,
Thank
please?
you.
Sai Meenakshi, ma'am, CV, please.
Yes, ma'am, it was shared.
So, ma'am's an obstetrician, gynecologist, former associate professor from Chengalpet Medical College, vice chairman Sai
Thank
Specialty
you,
Hospitals.
Barney. It was wonderful.
Thank you, ma'am.
Thank you.
Over to
Thank
you,
you.
ma'am, to introduce our moderator.
Thank you. Thank you. Very good evening, honored speakers and our beloved and loved OB-GYNs and cardiovascular specialists. I'm really privileged and honored to chair this session on CVD and menopause risk assessment, screening, and management. Initially itself, we had a wonderful curtain raiser for this panel discussion with our honored, learned, experienced faculties, cardiovascular specialist, Dr. Amrita Ganesh, who spoke to us on cardiovascular health risks on all menopausal women. And Arun Kalyan Sundaram sir was very elaborate on giving us a full insight into the prevention of serious illnesses risk. He mentioned so elaborately about the typical, atypical symptoms and what are all the predictors and what are all the preventive factors and all that. Thank you, sir. It was wonderful. It was very enlightening to learn many wonderful things. As Ganesh sir said, the importance of HDL, and you had mentioned about the atypical symptoms and how important is diabetes and metabolic conditions related to menopause and how it influences the cardiovascular risk. Thank you very much, sir. And we are again here to listen to a very elusive, elaborate, dynamic panel discussion. And this panel discussion is going to be on CVD and menopause risk assessment, screening, and management. Very eagerly waiting to get a brighter light, much brighter light on the menopause and CVD. Welcome, dear panelists. I'm very, very happy to have all the cardiovascular doyens and OB-GYN together on the floor. Welcome you all.
Thank you, ma'am.
Thank you. Over to Meera, ma'am.
The moderator, and she's our dynamic secretary, and she's been the person behind this whole program. And she's a consultant urogynecologist and robotics surgeon affiliated to Apollo Hospital Chennai and Chennai Specialty Clinic, and a board certified lifestyle medicine specialist. And she has returned recently from Taiwan after training the surgeons there in robotics.
Thank you, ma'am. Thank you, ma'am, for the kind introduction. May I request our panelist CV to be put on? I really am proud and happy to welcome all the panelists and my friends, both from Obs Gynae as well as Lifestyle Medicine stream. Professor Amrita Ganesh, who's now recently taken over the department at AIIMS in Mangalagiri. And he's been very kind. Within 1 week of the relocation, he had agreed to be on board and sent his article as well as his inputs for this program. Thank you very much, and really look forward to a very dynamic panel today. And my dear friend, Arun Kalyanasundram, you heard him already. Very elaborate CV and so many laurels to his accolade. So welcome, Arun. Thank you for being here. My mentor, my guide and trainer, Dr. Sheila Nambiar, again, board certified lifestyle medicine physician, fitness consultant, and a founder member and past president of Indian Society of Lifestyle Medicine. I had the great privilege of working with her as an organizing secretary for a very nascent lifestyle medicine international conference, and it was a fantastic experience. Welcome on board. Thank you for being here. And next slide, please. Dr. Subhashini Venkatesh, who is a general practitioner, preventive health physician. She's just now texted me. She's going for an emergency at Apollo, but she will return soon. And she's the preventive health clinical lead, IT and innovation. And she brings in light from the preventive health check perspective, why we need preventive health checker, which is why she's on the panel. Next slide. And a dear friend, Madam Dr. Rajshri. She's from Sri Swasthya Clinic, executive member of OXY, and chairperson for OXY Safe Motherhood Committee, and contribution to the management of labor in the textbook of postgraduates and practitioners. Welcome, madam. So we have a congregation of preventive healthcare physician, lifestyle medicine specialists who also are specialists in obs and gynae consultant, and practicing cardiologists, both intervention and lifestyle preventive cardiology. So we're going to get the maximum out of it, not only for our patients, but for all ourselves as well. So we will be able to practice what we preach and get better quality of life. So looking forward to this. Sahiti, could you please display the PowerPoint?
Sure, ma'am.
Thank you. Please go through the model this time. It has fantastic articles from all our panelists as well, from different perspectives. So it'll be very useful for us as practitioners as well as for our own lives. Thank you for that. So I have just quoted your abbreviation so that you can pick up the appropriate question. So next slide. So menopause is the time when every sweetheart turns bitter. The first question to Professor Amrita Ganesh: what risks actually are women exposed to in terms of serious risks around menopausal age? Is it just ischemic heart disease? What else could happen? What are all the systems could be affected?
Basically, every system is affected, starting from their functional, they have depression. In fact, all the vascular territories are involved in them. Abnormal obesity, abnormal lipid profile. Especially, I want to highlight again that HDL issues. Some patients in menopause who have a normal HDL doesn't mean they are normal, because the HDL usually is a scavenger which cleans the LDL from the periphery. But they're all inefficient there in perimenopausal period. Actually, the HDL is not very useful, and very particularly their ApoB levels. Apolipoprotein B is the lipoprotein which is responsible for producing atherosclerosis. So these apolipoprotein B levels are very high in them, and in South Indian population, the measures of lipoprotein little a is very high in them. All these things favors atherosclerosis. Again, one important difference between the CVS risk in other men or in older women and in perimenopausal women is that they have atypical presentations. Number one. Number two, the pathogenesis of these MI is different. Many of them, they don't have any obstructive CAD. I've had at least 2 patients who underwent CT coronary angiogram 1 week prior to MI. They had some atypical chest pain. Somebody has done a CT coronary angiogram. For these 3 patients, CT coronary angiogram showed very minimal disease or no disease at all. The next week or within 15 days or 1 month, they had MI. So the pathogenesis of myocardial infarction in these patients is not obstructive CAD. It's just a plaque erosion, spontaneous coronary artery dissection, and the abdominal vasospasm in them. Most of which can be due to estradiol, but it is not the estradiol alone. It is the systemic manifestation of so many other hormones because of altered estradiol, number one. Number two, the abnormal stress coping environment with these women. Both these things favors MI in these patients. So the risk is slightly different. See, we all know when the sugars are high, we tend to try to control when the cholesterol is high, but we have to learn that this cholesterol is the atherogenic cholesterol is qualitatively deficient in these people. So it is always important. We have to advise intensive lifestyle modification, which moderately changes the efficiency of this cholesterol handling, apart from other factors.
Got you. Thank you. Thank you. Dr. Arun, does the risk increase as women age or live longer duration after menopause? Or is it everybody after menopause the same risk?
I mean, this is kind of a setup question. So first of all, thank you for that question. That's an easy one. You guys are all Tamil, right? Like, okay. So I owe a big apology to Dr. Meera Raghavan. I made her like actually chase me for a lot of these things. So thank
I would have come home. I would have come home.
Hey, but Netha, it was like really late night when I sent you the stuff. Okay, I had like
it's okay.
Anyway. So here's the thing. So yeah, I think from the talk, I think right from the perimenopausal time, like if you just plot age on the x-axis and risk of, let's say, CAD, it's almost like, okay, till premenopausal, you're kind of really good. And the transition time, like, I think Amrit also talked about this whole, it's not just when your menopause starts, when you start not having, and then the 12-month period, and then the whole perimenopausal thing, right? It starts, your risk factors really, like the whole cardiometabolic health, everything goes for a toss, right? And then your risk starts going up, and quickly you catch up to men. And if you don't address all the risk factors that we talked about, namely hypertension, diabetes, cholesterol, etc., it puts you at an even higher risk for CAD than for men. And that is why I think, even for age, adjusted cohorts of women and men, after that point, women quickly catch up and actually beat men in terms of like, how, overall events and deaths. Add to the fact that you have, and this is something that we're talking about pathogenesis, we're talking about all this stuff. But my biggest thing is, please don't try like place too much emphasis on just the risks, etc. If you know someone is at risk, be pretty aggressive in treating. Amrita Sanma, like, be aggressive about the lifestyle stuff. Be aggressive about treating the traditional risk factors too, because they have a very, very strong bearing on your outcomes. So the risk does increase with age for all of us, right? I mean, as human beings, age is one of the strongest predictors of coronary artery disease. But what we see in women, which we don't see in men, is this big quantum jump all of a sudden around perimenopausal, and then boom, you overtake us. So, and I think the nice thing that is that lifestyle contributes significantly to that. A lot of these risk factors are modifiable. So I think there's a lot of room for us to we can make a lot of headway, number one. Number two, I think be cognizant of symptoms, be pretty aggressive about like when you ask them about, depression or vasomotor symptoms, whether they're just feeling like, extraordinary fatigue, shortness of breath, not just the traditional, oh, well, you're on a chest pain, check. So I think that is super important, especially post-menopause, regardless of age. And have a low threshold for also appropriate referrals. I think that's also something that I see that something that doesn't happen much. The one other thing I just want to say while I have the thing is, around pregnancy can also be a very good time, because I'm assuming, I don't want to assume, but a lot of you guys probably see them around the, when they're pregnant, etc. Use it as a teaching moment for lifestyle, because, for the kid as well as for the mom, I think, in the long haul, if they can change their lifestyle at that time, it will have a telling effect long term.
Thank you. That was wonderful. So catch them young. That's appropriate. So it plays for lifetime. Next question to Dr. Sheila Nambiar. I'm going to club the next two questions as Dr. Subhashini will join us later. Is the CVS risk safe for all menopausal women? And why do women of menopausal age need screening, in particularly for CVS?
Thank you for that. No, the CVS risk is certainly not the same for for all menopausal women. Like both Amrita Ganesh as well as Arun have already explained, you will need to go into a proper history, a much more detailed history of the woman. When did she have menopause? The earlier the menopause, obviously the risk is higher. What are her symptoms like? Does she have very severe vasomotor symptoms, in which case you need to be a little more vigilant about her? I would also look at other symptoms like her sleep, for instance. Definitely take a more detailed history of her diet, because we know how much diet affects your cardiovascular risk and health. And look at the psychosocial factors, which we often tend to forget. Who is she living with? What is the relationships like with the person that she's living with? Does she have a toxic relationship which is causing her a lot of stress, for instance, whether it's the mother-in-law or maybe the husband? So we need to go into a very detailed psychosocial, as well as, like both the cardiologists said, depression seems to be a huge factor in increasing the risk for CVD. So the detailed history for a woman with menopause, in and around menopause, is extremely important, covering all the aspects of lifestyle. And why do women need a menopausal thing? We've already heard extensively from both cardiologists that the risk for CVD goes up exponentially for women once they hit menopause transition. And in fact, it can actually beat the incidence for men. So aggressively screening all menopausal, even before they actually attain menopause. I mean, ideally, like Arun said, you've got to start them young. Screening needs to start much younger, even at 40, I would say. But definitely in and around menopause, you do need to screen. Besides this cancer screening, severe screening is absolutely mandatory.
So, Dr. Rajshri, what hormonal changes in menopausal women predispose them to higher serious risks?
Thank you.
Any
First of all,
specific things?
I would like to thank the Chennai Menopause Society, Dr. Meera and Dr. Shanti Gunsingh in particular, for giving this opportunity. Hormonal change, we know that there is loss of ovarian hormone, basically estrogen, which is responsible for predisposing and putting the women at higher risk. It especially acts on the endothelial lining, as was already described by Dr. Amrita. Even in the heart as well as the bone, it mainly acts on the endothelial lining, and thereby it affects the system, and it puts the women at a higher risk for the cardiovascular risk.
Yes, thank you, ma'am. On that note, I would like to mention that it's not just estradiol, because there are peripheral tissue which also produce some amount of estriol thing. It's the FSH levels also. So menopause is associated with significant increase of blood pressure, BMI, obesity, and redistribution of the body fat. And there is definitely increased risk after menopause. There's dyslipidemia and cholesterol accumulation, which may be associated with estrogen deficiency because of the sex hormone binding globulin levels. And as Madam rightly pointed out, it's the ovarian hormone lack which increases the LDL-C, triglycerides, and a decrease in HDL as well. So the qualitative nature of the lipoprotein also matter. And the blocking the FSH signaling lowers serum cholesterol levels by inhibiting hepatic cholesterol biosynthesis. So this is very, very important, which probably tells us why all our premature menopause or early menopause patients are at much higher risk of developing the CVD, which is why we need to give them HRT to prevent this FSH signaling, which can potentiate the cholesterol synthesis. This we all should be, really more proactive about it. And the first step is to avoid unnecessary surgical extirpation, surgical menopause. So we are should be more proactive and try and protect the womb and the ovaries as much as we can.
So, Dr.
Next
Meera,
slide,
if I
please.
can,
Yeah.
if I could just ask, because I mean that's what the data that's out there also seems to indicate. So, are you guys actually doing it? Because I mean, I know it got a lot of bad press once upon a time, right, with the whole women's health
Yeah,
initiative.
but it was not well
No,
dissected out. Yeah.
I'm totally with you on it, but I don't see a lot of the patients who are, I mean, because we do see some with diabetes is that who have coronary disease, but almost none that I've seen, right? And none of them are your patients, so I'll give you that. But none of them are on any kind of HRT. Like,
I'll tell you
although,
why.
like, they're in their 40s, they've had menopause. they see me for blockages. But I mean, when I go through the medicines and I'm like, I just tell them, hey, talk to your OBGYN about this because you might, but I don't see enough of this. So I actually wanted to like completely agree with you on this. I just don't see it enough.
Yes, and if they are premature menopause and early menopause, they are candidates for HRT till the time of age 50, because that is the average age of menopause otherwise. But if they are remote from the time of onset of menopause or after 60, we do not give them HRT. And if they've already had MI or a cardiovascular stroke or a disease, then the HRT is held back because that kind of accentuates their risk of developing further exacerbation and complication. So this is the window of opportunity which I'm going to come to. And I think this is one of the forum we will try to emphasize this take-home point. And I'm glad all the panelists are on the same page, and this is what we're trying to get across. Thank you, Arun, for that. Metabolic syndrome. Is menopause a separate factor for rise in metabolic syndrome? Dr. Rajeshri, please.
Yes, metabolic syndrome, yes, is a separate factor. I mean, menopause is just a separate factor for rise in metabolic syndrome, as it leads to changes in the lipid profile and increase in the atheromatous plaques and then strokes, which is all a part of metabolic syndrome. Yes, menopause is a separate factor for rise in metabolic syndrome.
Okay. So we know there are women with metabolic syndrome previous to menopause as well. Does that put them under higher risk of CVD after menopause? Dr. Amrita or Dr. Arun can take this. Hello?
I think definitely already the metabolic syndrome in them predisposes to a higher CV risk. Again, menopause adds to it. It actually multiples exponentially in patients with metabolic syndrome. Yes, definitely. Yeah. Studies have shown that actually. I'm not able to quote the study, but definitely it is there. One paragraph is given. Those who already had metabolic syndrome, the risk of CV events exponentially increases. Not only CV events, stroke also exponentially increases in them.
Yeah, thank you. $1 million question again to Dr. Sheila Nambiar. Can you reverse metabolic syndrome?
Yes, you can. But having said that, it's not easy because the lifestyle factors that need to be modified, it doesn't happen overnight as with medications. It's not such an easy thing, but it can be reversed, or at least, let's say, put into remission if you continue with the lifestyle factors. The thing is that it has to be continued. And for that, one needs to have consistent motivation, inspiration, and that's where the coaching comes in. So it's not just about them coming to see you once in 6 months. It's about consistency in between to help them sustain their exercise, their diet, and the other lifestyle-related factors.
It's kind of hand-holding them through. And it's not just for Christmas or a wedding, it's for life.
Yeah.
Thank you. Thank you. Dr. Arun, can you prevent CVD risks even if there is a familial predisposition?
I believe so. It's not easy, but I believe so. I mean, I kind of echo what Dr. Sheila Nambiar just said. So, hey, first of all, it's good to see everyone. Hi, Dr. Nambiar. Okay.
Hi.
So, no, absolutely, right? So you can definitely mitigate risk, but this calls for a lot of discipline. It's not these, oh, I'm going to do this, for the first 10 days once the new year starts. It's a journey. It's hard, but it's doable. And I think it really nicely ties upon like the next question that I think I'm supposed to take anyways, which is, I think every parameter, right? Whether it's your, low HDL, high triglycerides, high glucose, high waist, you change your lifestyle, that's going to have a telling effect on each one of these parameters, because each one of these parameters does contribute to your CAD risk. Now, again, we can split hairs and say what is the attributable risk of each of these. But the nice thing is we don't have to, because when you make these meaningful changes in your lifestyle, it actually will have a beneficial effect on pretty much almost everything. And for what you don't, you always have pharmacotherapy as your add-on. That shouldn't be your go-to in the first place. So yes, and remember, and I think I'm kind of preaching to the choir here, but like it's not just your genes, it's also good lifestyle can also affect your epigenetics. So it's about which genes are triggered, what's going to happen, etc. So it's not set in stone, so yes, you can, but it takes effort.
Okay, thank you. And I think you've answered the next question as well alongside. So if you make minuscule lifestyle changes, all the simple 7 can have a wonderful effect and thereby alter your lifetime risk of having a CVD as well. Thank you. Next slide, please. So we've gone through all this already in the talk. It's about knowing what are at higher risk and where to put your targets at. So elevated waist circumference. So basically central adiposity. So even if you're a low BMI, if you're a central adipose person, you're at automatically higher risk of CVD, which automatically will be telling on the elevated triglycerides and the reduced HDL. Now, reduced HDL is because of lack of exercise. You exercise, you make it better. There is no medication for that. And elevated blood pressure and elevated fasting glucose. So these are the main things one should concentrate on, the parameters of metabolic syndrome to make changes so they can reduce the risk of having a CVD or a stroke in the future. Next slide, please. So going on to primordial prevention, this is where we all would like to score because we do not want a problem and then be acting on it. So what are the screening tests we would do for a general population of menopausal women with respect to CVD risks? Dr. Amrita Ganesh, and you can take the next question as well about Framingham risk score.
Yeah. Mainly, I feel that we have to take a detailed history in them actually about these vasomotor symptoms, depression, and the insomnia, sleep disturbances. Because many of these patients, at least all of you would have faced that they come with some problem or other. We attribute that to the family problem, or we try to ignore them. So we try to take a detailed history of what is happening to them. Again, most important, before assessing their risk for CV events, I would put a score on them, like as rightly mentioned, Framingham score. FRS is originally devised in late 90s actually, which contained cholesterol, HDL, so many risk factors. But modified FRS deletes that diabetes. Diabetes is no more included because they consider diabetes as directly CAD equivalent, which is not so actually. So a proper history, and then if at all you want to screen, the most common screening test done is, apart from a lipid profile, you do apolipoprotein B in them, which tells you atherogenic risk factors, lipoprotein A, vitamin D, and B12 levels to assess the proper associated risk factors. And most importantly, we started doing coronary calcium score in many of them. If the coronary calcium score is a very simple, non-invasive test which can be done in them, if it is high, then we can initiate straight away the preventive risk factors and straight away an indication for antiplatelet therapy. One test, as I really mentioned, TMT, which is often misused in these patients, is TMT. TMT in the perimenopausal stages should be properly done, because when I order a TMT, I know why I'm asking for it. Because many of these patients will have non-specific STT changes in them, and ultimately it will be reported as positive TMT. Once you report positive TMT, and we'll be continuing on coronary angiogram, may not show any findings, and they are stuck in that. So before ordering a TMT, I would be very careful in these perimenopausal women, because false positives and also false negatives are very common. So before ordering TMT, if I want this TMT for effort tolerance, I would check the effort tolerance and keep it up with it. So calcium scoring is really helpful in this stratification. The calcium score is abnormal. Yes, we do initiate intensive lifestyle modification along with the statins and antiplatelet agents. Apart from this Framingham risk scores, we have Q2 risk score, and then we have ASD risk score. These can be modified we can apply them in them to decide on how much statins they need.
Okay, thank you. Next, can you display the slide? I'm not able to view the slide. So Framingham risk score is an online calculator. You can do this tells one's risk of developing CVD or stroke in the next 10-year period. Gender, hypertension, HDL, and total cholesterol, age, smoking, and diabetes are taken into account. Can we go to the previous slide? I have a few questions to ask the other panelists. So, Dr. Arun, what does Framingham risk score predict? You've answered that. What exactly is coronary calcium score? What is high? What is low? How do we interpret it?
I mean, I always interpret all these risk scores with a word of caution, right? I mean, I think it's helpful to stratify to an extent. And I think the slide that you just showed pretty much answered it. I mean, you could predict your 10-year risk of, like, let's say stroke, heart attack, either. While these are helpful, I think they're not set in stone. It could be like, it shouldn't lull you into a false sense of security, or you shouldn't overread it. Remember, this was done in Framingham a while ago. We have newer emerging risk factors. I think in India, our prevalence of coronary artery disease is clearly higher. It's at a younger population. We have a lot more diabetes. So I would interpret all of these with and I say this even when I talk to cardiologists, it's like, it's a score. So you got to put things in the big picture, right? And for me, the other thing that's always kind of bothersome and interesting is, if you look at all the data that came out with EBCT and calcium scoring, etc., only acceptable score in my mind, or what I want to shoot for, is 0, right? Yes, the more you have, the higher the risk. Obviously, it correlates, because remember, calcification is oftentimes the end result of atherosclerosis, where it's like a volcano's erupted a little bit, whatever, erosion, plaque rupture, whatever, micro things have happened, and then you have calcification on top. It's like actually the sequelae. So it means even a score of 1 actually does mean that the process has already started. Obviously, if you have greater than 100, greater than 400, it correlates with the extent of atherosclerosis, gives you an idea about the overall burden. So it's always one of these things where, well, if it's 399, you're okay. Honestly, that's you don't understand what is a continuous variable and what's a discrete variable, right? So it just means that it's really not, there's no seismic jump from one particular number to another. So in general, what you should strive for is, if you have a calcium score of anything less than 0, I take it seriously, right? Especially in the light of, let's say you have a 35-year-old guy or gal, whoever, who's just got premenopausal or postmenopausal, for whatever reason, surgery, etc., who's got a calcium score and who has got these atypical symptoms, I would definitely look into it more, right? So don't blow it off, and again, put things in the grand scheme of things in the overall perspective.
Can it be lowered by interventions?
What?
Can the calcium score be lowered?
No, it cannot be. As he rightly said, calcium score can be a predictor. We can learn about intensive. As he rightly said, any score 0 is advisable. Anything more than 0, they say they classify into 100 to 400 more. But any score more than 0 is already, as he said, the process has started, and it cannot be reversed. We can only prevent the further progress, definitely.
Correct.
And
that's
ma'am,
exactly
the goal, again, just for those patients that are obsessed about the number, right? Sometimes you're like, oh my God, I got 400, but I need to get it to 350. The point is, like, as we get older, all of us included here, right? We get changes in our bodies that are, some of which are just irreversible, just doesn't go back, right? We're not yet at that stage in medicine that we're going back. So the key is it something that's going to kill you, or is it something that's going to make you horrendously symptomatic? And if the answer is no to both, then I think we can learn to live with it. Just tell them, hey, look, this is okay. But the key is prevent further progression, as Amrita just said. Like, ensure that you're not doing those things that led to this in the first place. Now, I mean, for me, it's all a tiered approach. The primordial prevention, primary, secondary, interventions as appropriate, and then whatever else. The goal is to lead a good, functional, and a fulfilling, happy life. So I wouldn't get too much, too hung up on the score per se, or trying to reverse it per se.
Thank you. What kind of interventions can be instituted for a high-risk FRS, Dr. Sheila, in terms of lifestyle?
So if it's a high-risk person, I certainly would like to work in concert with a cardiologist, because I don't think this is something that can be managed on, just with lifestyle. For instance, they may require antihypertensive treatment, they may require statins, they may require whatever has to be managed if they're already high risk. But lifestyle becomes one of the interventions that can be introduced, starting with primarily plant-centric diet. So eliminating all the risky substances that they're consuming, maybe the trans fats, the processed foods, the high sugar, the refined grains, which India is typically famous for. It's not just the fats. I think the grains, refined grains, are also a huge problem, and the refined oils. So we need to look into their diet. How much are they exercising? Starting slow. You don't start a person, who's never exercised before and tell them to run a marathon. You do start very slow, and at least try and accomplish the 150 minutes per week, which in my opinion is not sufficient, but it is the minimum requirement. And definitely start to introduce strength training. And I think we'll be discussing muscle and all that a little later. Look at the other aspects of their biopsychosocial situation. Again, what is their psychological profile? Because from what I have experienced and what I have seen with patients, it is not just the exercise and the diet and the sleep. They are all very interconnected with her psychology and with the with how she has experienced life, including her childhood experiences, adverse childhood experiences. So we cannot just focus on what is happening now, which is a plan. You plan to exercise, you plan to get her to eat better, you plan to get her to sleep healthier by giving her the advice for sleep hygiene, etc. But looking at the bigger picture of what is she stressed about today and what is her response to the stress, because all of us have stress. How is she responding to the stress? Is she responding in a better way? And if she's not, what can be done? For instance, mindful meditation, various other form of relaxation techniques. What is trying to address, for instance, what is causing her to respond in this particular way? And in that, for that, you may want to, if you've not done, for instance, if you're not able to address the adverse childhood experiences, you've not had exposure to positive psychology and the positive psychology interventions, you may want to work with a psychologist who is familiar with these things and address the bigger picture. Because from what I've seen, just telling a person to exercise and telling a person to eat healthy is not sufficient. You need to really understand why she's not doing it.
Thank you. Thank you. Dr. Rajshri, what is window of opportunity?
Yeah, so the primordial prevention has already been discussed by cardiologists. Any young woman who walks in, it could be preconception counseling also that they come for. We have to look at their weight, the BMI, and then the family history. And then we start telling them about the risk factors, check their blood pressure. It starts there. And then again, during pregnancy, the risk factors which put them at a higher risk for cardiovascular diseases, which are there when they have hypertension or diabetes, gestational diabetes, preterm labor, all these puts them at a higher risk. And finally, when they are in the menopausal transition and when they come to us with a history, of irregular cycle, we take it as an opportunity to tell them about the cardiovascular risk, and then about the BMI, the blood pressure. So at each step, we take it as an opportunity to tell them regarding the risk, about the lifestyle management, the blood pressure, and the changes that they need to implement.
Thank you. Next slide, please. Next slide, Sahiti. Next one. So now that we're discussing menopausal women, Dr. Rajshri. Yeah.
I'm going to be gone for give me 5 minutes. I got a patient on the table. My junior is doing it, but I got to go check in. I'll be right back. Okay,
fair enough.
Okay. I'll try and be back ASAP.
Sure. What is calcium paradox?
Yeah, it's a massive cellular destruction that occurs when the myocardial tissue is perfused with a calcium-containing solution after a period of calcium-free perfusion. We all know that it's a paradox because when there is no calcium, there will be necrosis of the myocyte. But actually, when there is a lack of calcium and when a calcium containing solution is perfused, it results in cellular destruction, which probably would be because of the cellular membrane damage which would have happened during the loss of calcium. Therefore, it's a paradox because it happens after calcium infusion is given.
Okay, the same thing
I
happens.
feel it is described in a different way clinically. In
Yeah.
perimenopausal woman, on one side you have osteoporosis, on the other side you
Correct.
have calcium deposition. That is
Correct.
actually interpreted as calcium paradox, I think.
Absolutely. In clinical terms, in menopause, we find the bones losing calcium, but everywhere else there is dystrophic calcification, not the typical calcification. So you can have renal disease, you can have atherosclerosis and coronary artery disease, stroke, and so on and so forth. That is what happens with calcium paradox, which blends to the next question, which I think Dr. Amrita Ganesh already answered. Osteoporosis associated with higher CVD risk? If so, why? Dr. Amrita Ganesh, you can take that question and the next one.
Osteoporosis, see, I don't think osteoporosis per se, there is no correlation. I don't think there are any studies correlating directly osteoporosis with the high risk. Again, this osteoporosis in perimenopausal is the extensive topic to be discussed, what to give and what not to give. Actually, as lifestyle physicians, we learned that evidences are mounting that milk is not that helpful. Still, people everywhere advise 2 tumblers of milk every day to prevent osteoporosis, and 2 great studies have proved really that I showed before. Milk supplement may not be essential, but I don't think osteoporosis is directly associated with high CVD risk in any perimenopausal women.
So probably.
So what adjuvants are specifically needed in women to avoid calcium paradox is to give vitamin K. Actually, we cannot be without supplementing. We cannot be without supplementing calcium also. The only thing is to be very useful for them, we need to supplement with vitamin K supplements so that these calcium and vitamin D are very useful in replacing the bone.
Yeah, that's exactly another take-home message I wanted for everybody. So supplement with vitamin K as well. So maybe you can take, or Dr. Sheila Nambiar can take, because Arun is out there. Is calcium supplementation contraindicated in women with risk of CAD, higher calcium scores, or family history of CVD? Because we get patients nowadays who say, doctor, I've been told my coronary score is high.
Yeah. I don't know the direct connection between supplementation and calcium scoring. I'm not too sure. Amrita Ganesh, maybe you can answer that.
So far, no studies addressing that. No, it is not directly related, definitely.
Directly related.
So there's no contraindication.
There's no
contraindication. No, absolutely no contraindication.
Yeah. So
okay.
The next.
Then, yeah.
Is it a blanket supplementation? No, I don't think it's blanket supplementation is required. However, 500 mg of calcium for a woman, especially if her diet is extremely poor, especially if she has not been strength training to increase her bone density, yes, it is required. But I think, again, a history is important. You don't just prescribe the calcium without understanding her lifestyle. Now, for instance, if she is already exercising, using strength training regularly, 2 to 3 times in the week. And when I say strength training, I mean really strength training, not just using very, very light weights. And if she's eating, if on analysis of her diet, you find that she is eating adequate calcium, then it's not required to supplement it. But if you find that her diet is inappropriate, it's not, not reaching the adequate amounts of calcium, and she's not really exercising, weight-bearing exercise are not sufficient, then yes, definitely you will need to. Because as I think Amrita Ganesh or Arun said, it's not as if adding calcium to your diet or supplementing it actually reduces the incidence of fractures. We've seen, and the studies have shown that those countries who don't drink milk and don't consume as much dairy don't necessarily have less incidence of fractures. So we need to be a bit careful about prescribing it as a blanket to everybody.
Thank you. Thank you. Next slide, please. Sahiti, next slide.
Yes, ma'am.
So please, next slide. I'm not going to waste much time. I'm wary of the time as well. So what do you do for general population when they come to you worried about, family history or whatever? Dr. Sheila Nambiar can take the first two, dietary advice and exercise regime for them.
Yeah, we've already stressed. I think diet is probably the most controversial subject. Everybody has a different opinion on high fat, low fat, high carb, low carb. But essentially, what everyone agrees with, and let's just focus on what we agree with, is that you remove the processed food, you minimize the intake of sugar, increase fiber, especially from plant products like your vegetables, fruits, nuts, beans, seeds, increase the amount of soluble fiber, which will reduce your cholesterol. Those are the basic rules for diet. And again, just giving them a diet, just prescribing, writing a prescription on a piece of paper and giving it to them is not sufficient. Actually following up with food journals or with pictures of their food and having a guide or a coach assist them at least for the first couple of maybe weeks will definitely help, because you will have to give them, for instance, what I find really interesting is that considering that India is primarily a vegetarian country, Indians find it very difficult to consume enough vegetables. And if they do consume the vegetables, they consume them completely ruined by overcooking and over seasoning. So you do need to guide them to eat the right kind of vegetables and the right kind of nuts, seeds, beans, etc., etc. Exercise, the general population as WHO guidelines.
Hey, you can get changed and go down. I'll come down in 2 minutes. Okay.
Yeah, exercise, general guidelines says 150. You can start with that 150 minutes of cardiovascular exercise. That is 5 days in the week, which could be anything of their choice, whether it's walking or swimming or cycling. And I always advise a low impact activity. You don't start off with running or, skipping. And gradually increase intensity in order to increase cardiovascular endurance. Please add strength training at least twice a week, minimum twice a week, addressing all the body parts and the major muscles, and add some form of flexibility, either in the form of yoga or just simple stretches. That can be done in about 5 to 10 minutes, which is why I'm saying 150 minutes really does not suffice. You would have to say at least 60 minutes, in my opinion, 60 minutes, 5 to 6 days in a week.
Okay, thank you. The next two questions to probably Amrita Ganesh. Do you advise BMI as an important thing, or a waist circumference, or an entire body composition analysis?
Yes, that's what, because many of our physicians are not exposed to completely body composition analysis, and rather they don't know about lean body mass with the obese indices in them. So definitely every one of us should be exposed to body composition analysis or waist circumference only to assess their fitness and visceral fat, etc.
Thank you. Next, again, we've discussed calcium score. So Arun, you're let off now. Hormonal check, is it mandatory that you do for all the population who come to you around menopause time, Dr. Rajeshri?
No, we don't routinely do a hormonal check for everybody who comes to us routinely.
Thank you. That's not kind of going to predict what they are having. Yeah. And with regards to treadmill and risk scoring, Dr. Arun, do you do
We
for
have addressed
all?
that. Treadmill again, I want to give a caution on treadmill again and again, because in many centers, they again do treadmill. In the perimenopausal woman, lots of false positive and lots of false negatives, both are common. Once you have a false positive, their life is ruined actually. They come back to you frequently with the non-cardiac chest pain, and it's very, very, very difficult to convince them. Their whole life is ruined. So I would be very, very careful in advising treadmill in any perimenopausal woman unless I know what I want. For example, effort tolerance in terms of meds. If I want to measure only that, I will not bother about. In fact, there is a blank statement in Braunwald. If anybody has done more than 12 or 13 meds, irrespective of the ECG changes, irrespective of their coronary anatomy, irrespective of angioplasty or CABG, their prognosis is not going to get affected by anything. So I would be very, very careful in advising a treadmill If at all I want to rule out inducible ischemia, I would suggest either stress myocardial perfusion imaging, MRI, or nuclear scan, which tells you if there is no inducible ischemia, then you are done with it. In fact, in the two trials, ischemia trial also, people who had intensive lifestyle modification, control of diabetes, everything, in fact, they had reversibility in inducible ischemia, not with calcium. So I would be very, very careful in advising treadmill. Coming to risk scoring, there are no specific risk factor scoring in people in India. Why? I did actually a pilot study during the Corona period, and I tried to involve all these scoring factors like ASCVD, Framingham, Q-risk, JSB, all things I did. In already, if a patient comes to you with MI, I tried to implement these risk factors and try to find out which scores really matters. According to me, all scores did the same thing. But better not to have, better apart, suppose we don't have anything, you can use FRS. Something is better than nothing. Though we don't have an Indian score, Framingham is highly sensitive. There are highly false positives. But still, if you use in our population, it's okay. If you have a false positive, of course, when you go for intensive screening, it's okay. So any single scoring can be there, not a must, as Dr. Arun said.
Okay, thank you. That's a good message out there. Next slide, please.
Hey, I'm gonna real quick ask, guys. I do have to be down in my lab, so I just came to say
carry on.
Thank you very, very much.
Thank you.
Wonderful discussion. I think Dr. Amrita Ganesh will hold the fort on behalf of all the cardiologists. Thank you so much. Thanks again.
Thank you.
I really appreciate it. Thanks.
Thank you. Thank you.
Thank you,
Thank
sir.
you. Thank you, AK. Bye, bye, bye.
Thank you, Arun. Thank you.
Thank you, sir.
Next slide.
Thank you, Arun.
Next slide. Sahiti.
Sahita.
Sahiti, please. Next slide.
Sahiti.
Shahiti, change the slide, ma.
Move it. Keep moving till I tell you, because there's lack of time. I want to go directly to the rapid fire. Next slide. Next slide, please.
Shahiti, change the slide. Huh?
Next.
Keep moving till Dr. Meera says stop.
Yeah, please. Next. We've discussed all this. That's why. Next. Okay. Dr. Sheila, what are the specific diets? I've put DASH portfolio, low carb, high carb, low fat, Mediterranean diet. What would you tell somebody who's looking at reducing their risk of CVD or who has a family history? Or what's general advice so that they don't develop a coronary event?
So depending on what their blood pressure and what their cholesterol levels are, we could prescribe either DASH or portfolio. If they have a high blood pressure, you have to prescribe DASH. This low carb, high carb, low fat, I would be a bit careful about labeling them as low carb and high fat, etc. Because the problem with that is, first of all, you become fixated with these terminology rather than actually eating healthy. You're just focused on, one particular macronutrient. My advice would generally be, while the Mediterranean diet, I think, has been recommended as something that is healthful and is, universally accepted, my recommendation would actually be to focus on whole foods primarily, remove processed foods, as I've already said before. And when I say whole foods, what I mean is whole grains, whole vegetables, fruits, nuts, seeds, beans, and completely eliminate, or to the best possible extent that you can, remove sugar or any other sweetening agent for that matter, as well as processed food. And I would really focus on the entire meal rather than just one macronutrient. Because when you say something like low carb, for instance, people tend to eat more of animal products to get in the amount of protein that they think that they should get. And we know that, just about 0.8 to 1.5 grams of protein per kilo is required, and that can easily be achieved even with a diet that doesn't have animal products. So you need to be a bit careful about this high carb. Now, if you say high carb, you know, areas in the world like the blue zones, for instance, do have a high carb diet, but they focus more on the carbs that are higher in fiber. They don't look at carbohydrates which are processed, like your maida and your biscuits and your cakes, which are also carbohydrates and can actually account for a high carb diet. So the terminology is slightly difficult to follow and also have a healthful diet. So we need to be a bit careful.
Yeah. So basically, we have to switch to calorie dense
Yes.
products or calorie rare products rather than group them into high carb, low fat. Because we don't shop for carb or fat. We don't grocery shop in that way. So why eat it that way? So that is the message out here for everybody.
இன்ஃபேக்ட் மேடம் நாங்க ஆந்திரா வந்து இந்த இங்க சாப்பிட்றத பார்த்து பயந்து போயிட்டேன். they eat lot of rice. நிஜமாவே not exaggerating. Lots of rice with slow vegetables தான்.
Yeah, true, very true. Majority eat that way. It's not just about that. It's about lack of nutrients. And I very much like what Dr. Amrita Ganesh told that time. It's not just your cholesterol. It's not just your rice. It's not just your protein. It's about your vitamin D, B12, everything. Because vitamin D is also involved in your cholesterol pathway. If you're vitamin D deficient, there is the same substrate can go into the cholesterol pathway. So it's important to understand these deficiencies and do the supplementation accordingly. And majority of the vegetarians do not have vitamin B12. Majority of the diabetics on metformin are B12 deficient. If not all of them are B12 deficient. So these are all very important aspects when you're dealing with the nutritional and dietary advice. Thank you for that.
Ma'am, with
Next
respect
slide,
to
please.
B12, only one point I want to add about B12. I have seen lot of non-veg being B12 deficient. I went to the literature. South Indian population, we are lacking in intrinsic factors.
Intrinsic factor, totally. Intrinsic factor. And people with IBS, inflammatory bowel disease, will be B12 deficient. So it's very, very important to say that as well while you're treating somebody. Thank you. Next slide.
One thing, Meera, I think a lot of people are eating packaged foods these days. So be understanding the nutritional information at the back of the package is also important, because we don't really pay attention to the added sugars, the amount of saturated fat, etc., etc. So that also becomes a little, important.
Yeah, totally. Thank you. So, what are the barriers in taking up preventive health screen as such? Anybody can answer this. And what
First of all, somebody should be a role model like Dr. Sheila. Actually, when I met her in Ooty first time, I was astonished. Actually, from that day onwards, for the past 3 years, I've been following this lifestyle. It's very difficult to pursue. I am spreading the message even in AIMS Mangalagiri. Whenever I see a student or any group, I immediately start telling them about lifestyle. It's very, very important that we should have a separate this thing on counseling for lifestyle. It's very, very difficult. Very,
Absolutely.
very difficult. Yeah.
I can fully understand what Dr. Amrita Ganesh is telling. So it's her way of training and mentoring is quite infectious. So thank you for that. So what are the obstacles one faces while counseling on lifestyle? Because it's quite tedious and it's not easy, as we know. So Dr. Sheila, you can answer that. What are the obstacles you generally face?
So I think the main problem is that, when the person doesn't have a specific problem, it's very difficult to address it. Like, you see the problem, you see that obesity can lead to XYZ, or hypertension can lead to cardiac disease, but they don't see it like that. They just see it as it's something that can be dealt with on using a medication, and it's so easy, simple. You pop the pill and your blood pressure comes down, or same thing with diabetes. So when there is no pain, that is a pain point, that is wanting them to change, it's very difficult to actually tell them that they have to change and change their lifestyle in order to prevent future events, because they don't see the future event. So you see it, but they don't see the future event. But if they come to you saying they have a pain point, like for instance, they are obese and they're finding it very difficult, it's affecting their emotional as well as their physical, their productivity and so on, it's easier to start counseling them and easier to implement lifestyle because they already have the pain. But if you don't have it, it's like as for any screening, a woman who has no issues does not really want a pap smear. She wonders why you want to do a pap smear in order for you to prevent cancer in the future. So this is a problem. But I think the tide is turning. More and more women are actually coming, asking for how can I prevent diseases? Because of course, thanks to social media, there is a lot of information out there and it's getting a little easier for us. So yeah, that's one of the obstacles because they don't see the pain point at all. And of course, it doesn't happen overnight. So how long do you wait depends entirely on how effective, how persistent the patient or the client is, because you can give a lot of advice, you can give dietary advice, exercise advice, but unless they are consistent with it, things will not change. But if they are consistent with it, within a matter of a couple of weeks, even 2 weeks, if not a change in weight, they will definitely start seeing a change in many, many things, including, which I always tell the client, is look at your stool. Look at the stool and look at the Bristol stool chart. If you are eating a high fiber diet, you will have the kind of stool that sinks to the bottom, that is well formed, it's not inflammatory. That is, in fact, that happens overnight. So simple other things, like for instance, how do they feel mentally? Is there brain fog? Do they feel more alert? Do they feel drowsy after their meals? Do they feel that their mood is elevated? All these little things can actually happen within a matter of a week to 10 days. Your weighing scale may not move that fast, but I think if its consistency is there, you can see other changes within a week to 10 days. And what will you reassess? Definitely their diet. They have to send in their diet chart, or at least take a history of their diet chart, look at their exercise, how much are they exercising. Nowadays, with all these gadgets that are available, it's easy to assess, how many steps they have covered, etc. Your other screening, like your blood tests, etc., obviously, like I'm sure Dr. Ganesh will tell you, you've got to wait for a little more time for them to kick in. Maybe 3 months, I would say, Dr. Amrita Ganesh?
Yes, ma'am, 3 months. My triglycerides, after I became vegan, my triglycerides came down from 490 to 190 in 3 months. Still, I am maintaining that.
Yeah. Wow.
Awesome. Okay, thank you. Thank you for that. The very important fact is many people think preventive health screen is to pick up disease and tell you have a disease. It's not. It's to promote well-being and stay that way. So that is very important. I'm going to move the slide. Next slide, please, because we have discussed more on the screening and high-risk individuals. This is important. Primary prevention, role of aspirin and statin. Dr. Amrita Ganesh.
Yes, ma'am. Again, 3 studies have clearly shown that there is no role of aspirin in primary prevention because they end up in having more bleeding. That is why in intermediate population, they brought this calcium scoring. If it is really higher, then probably they may benefit from low dose aspirin in them. Statins, yes, definitely. We classify the role of statins in 2 groups, diabetic and non-diabetic. In diabetics, directly we have a measurement less than 70. But in a non-diabetic, anywhere between 70 to 190, I don't start them on statins first. I calculate the ASVD score. If it is more than 7.5 to 10, till I give them a chance for 3 months to 6 months, intensive lifestyle modification, and still if it is high, then only I start. In fact, I tell these patients, please don't look at your reference values. Usually these people know when they give blood reports, they give reference values and they stick on to it. Every physician I have seen starting on fenofibrate for a triglycerides of 250. I tell them, if at all you want to give some medication for triglycerides, you give omega-3 fatty acids and not fenofibrate, because statins and fenofibrate is a very bad combination. They come with extensive myalgia. The life becomes very difficult. So my threshold for starting fenofibrate is when the triglycerides are more than 500, as guidelines indicate. And statins, yes, in a diabetic, yes, if they are more than 70 in a primary visit, I start. For non-diabetic, if it is 70 to 190, I give them the intensive lifestyle modification. I advise them and then repeat after 6 months. If it is really high, with a good family, with a strong family history and calcium score, I start them on statins. Is statin diabetogenic? Yes. Some studies have proved that in some predisposed individuals, yes, there are instances where it has shown HbA1c increasing, but it is considering the benefits of statins, you should not prevent from statin treatment in a diabetic people. Out of all statin, pitavastatin is less diabetogenic. In fact, it helps in diabetic people. So if you are starting a statin for a primary or primordial prevention, I would prefer to start pitavastatin because it produces less myalgia. It is very friendly for diabetes. It is very friendly for improving your HDL, quality of HDL. These three improvement quality is seen with the pitavastatin, but it's less used actually.
Yeah. Weight loss medications nowadays with Ozempic and Mounjaro and the CVD risk, does it come down just because they are on weight loss medication?
No, the recurrence rate is very high. Weight loss medication doesn't directly prevent the CVD risk actually. Once they lose weight, it has to maintain. Otherwise, there is no direct. Yes, the studies of the semaglutide have shown that losing weight has independent risk reduction in avoiding CVD, but still long-term studies still are not there.
Okay. Now we see many patients on GLP-1 as anti-diabetic medication.
Yes.
Are they started on that for reducing CVD risks?
Yeah, definitely. Not for CVD risk, for obesity or diabetic. When they are obese, if you start them on GLP, yes, it has additional benefit of CVD risk reduction. So the CVD risk reduction is also an additional benefit to your weight reduction.
Got it. I know this is a very simple question, but many people don't know the answer. What is normal BP target?
After reviewing all the trials, there are some controversies. Still, in my day-to-day practice, I believe anything less than 140/90 is a target. Because going behind so much, for example, sprint trial, which proved that lower the BP, lesser the risk. For example, they tried to maintain 120/80. But when you look at the data carefully, those people who were on multiple pills for these BP control, they all had many side effects. We cannot imagine an Indian having a syncope on the road because of your side effects of BP medication, number one. Number two, many of these patients where we missed to screen about OSA. One of the important cause of BP, this thing is OSA. And we keep on increasing the drug and OSA will not be under control. So normal BP target, I still feel it is less than 140/90. If they have 130/80 is okay, but only above 140/90, I start on drugs. Otherwise, I strictly tell them, follow lifestyle.
Yeah. A very, very important take-home message again. OSA, if the blood pressure control is the problem, that's one of the screening for OSA itself. And OSA runs in families. So there is a strong family history. Everybody in the family should be screened for OSA. In fact, I have seen a 16-year-old with OSA and needing CPAP. It's not age dependent, it is familial, and I do it as part of my incontinence screening. And there are many OSA, and what we see is only the tip of the iceberg. So it's a very important. Thank you for that take-home message.
In fact, I motivate many of these gynecology PGs to take up urogynecology because I face a lot of female patients having incontinence, and when I send to anybody, they just do urine routine and then send them back. Very distressing, actually.
Okay. Dr. Rajeshri, what is the preferred route of hormone therapy?
Depends on the symptoms. It depends on the symptoms for which they come for. If it's urogenital, then we can give local creams and gels that can be given. If it is for vasomotor symptoms, yes, the transdermal route is preferred to the oral route, but the availability, the pricing and the compliance makes it difficult to use the transdermal route, and so the oral route is what we use. Is HRT for mitigating risk for CVD? The answer is not yet there, as already been discussed by the cardiologist. There is a timing thing. If you start it less than 60 years or less than 10 years after menopause, they say that it may have mitigating effect on the risk of CVD, but we need research, as has already been explained by the cardiologist. Is it contraindicated in already existing CVD? Yes, it is contraindicated in already existing CVD.
Thank you. Thank you. That's very clear. Thank you, ma'am. Next slide. Again, between all the lifestyle people, what kind of fitness? You've already answered that. What is exactly cardiac rehabilitation?
Amrit Ganesh, you can take that.
Actually, there is no actual definition. When the patient, after they undergo a procedure, either PC or CABG, rehabilitation has so many. For example, rehabilitating them to do the regular habit, the regular work, what they're able to do. For example, if they're able to walk 6 minutes, walk test, everything, and keeping all the risk factors under control during follow-up. This is what we actually do in cardiac rehabilitation. So rehabilitating them to do their normal routine work for a quality life. So what I do is that, again, I split into 4. I assess their symptoms, I assess their LV function, I assess their risk factors, LDL, everything. And then if they have any psychological issues, I send them to a psychologist where they counsel. And we can also send them to physiotherapist where they gradually train them. First, according to their LV function, they assess what is the current effort tolerance. They note it down and they advise accordingly exercises involving all the muscles of the body. And then they come after 6 weeks, reassess their effort tolerance, the physiotherapist. And nutritionist, they advise about, like Sheila ma'am told, whole food, plant-based diet, everything. So these are the 4 components of cardiac rehabilitation.
Yeah. Thank you. Can exercise tolerance and cardiac fitness be improved?
Yes,
definitely.
Definitely, it can be improved. Your exercise tolerance depends entirely on how much you've exercised. And what we find is that most people do the same thing every day, year after year, day after day. So in order for you to improve exercise tolerance, you have to introduce challenge. So unless you introduce challenge, your exercise tolerance and cardiac fitness will not improve. So it's important to introduce challenge.
That's great. Thank you. Next slide, please. Very quickly, rapid fire. 38-year-old woman undergoes THV with severe endometriosis. Family history of severe CVD. Mother died of a fatal MI at 55 years. What category risk does she belong to?
High risk.
High risk only.
High risk. Would you prescribe HRT, Dr. Rajshri?
Yes, she would require
Definitely.
because of severe endometriosis. She may require a combined if you've not completely eliminated the endometriosis during the surgery, you may have to add on progestogen, which may be a neutral progestogen like dufeston or micronized progestogen along with your estradiol.
Okay.
Ma'am, I have one doubt here. In a 38-year-old woman, can we preserve ovaries? BSO is necessary?
No, not for the endometriosis. The seat of the problem is endometriosis. So that's why she's had to undergo this. So, next slide. 65-year-old, menopausal for 14 years with MI, diabetic for 25 years. So what would be the recommended screening for her from a preventive cardiology perspective now? And then what kind of exercises can she take up? What exactly you would do on follow-up?
First, I would go into her symptoms. If she is really asymptomatic, then I wouldn't do anything apart from lifestyle modification. If she has some atypical symptoms which disturbs her from day-to-day activities, I would do a stress MPA to rule out inducible ischemia. If it is negative, again, intensive lifestyle modification.
Thank you. Next slide. 54-year-old menopausal for 2 years, brother and sister both diabetic. Sister developed an ischemic stroke at 62 years of age. Hypertensive for the last 2 years, this lady, and now has been started on statin for last 3 months as high LDL. What is the intervention which is most needed? Any other cardiac assessment and role of HRT in her?
No role for HRT.
Okay.
Lifestyle.
Okay.
Lifestyle. Yeah, lifestyle.
We need to
Any other cardiac assessment for her?
I don't think, apart from routine, I don't think any.
Only if she's symptomatic, you will go for
Yeah,
it. Otherwise,
yeah.
you don't need it.
Even
Got
a
it.
recent paper analysis from Italy and France, recent paper clearly proven that only if symptomatics, it could be atypical symptoms. Any new onset symptoms should be taken in especially in perimenopausal women. Atypical symptoms are very common, as in diabetes.
Yeah.
Recent onset fatigability, recent onset dyspnea could be an anginal equivalent.
Yes, yes. Do not, that's very, very important message. Do not disregard as it's probably related to your menopause or related to your stress or, sudden anxiety. These could be cardiac and especially symptoms of indigestion. So that also has to be taken into account. Next slide, please. So let's have the final word. Fats, oils, and heart. Is it always bad, Dr. Sheila?
No, it's not necessarily. When you have good quality fats, the monosaturated fats, they can actually improve heart health. So I don't think we need to avoid fats completely. It's the refined fats that are problematic. And of course, the trans fats, which are solid at room temperature. Those fats are kind of problematic.
So dalda, your vanaspati are out of question.
Yes,
so
absolutely.
that is again very, very important.
Palm
Yes.
oil, which is in every ration shop.
Ubiquitous available.
Yeah.
Unfortunate that it's like spoiling the health of the many. Multitudes. What is the magic about the ever spoken 10,000 steps a day? What's your final word?
Yeah, in fact, there was a recent paper about the number of steps and how it affects all-cause mortality, and it's been shown that an increase in number of steps does reduce all-cause mortality, but you don't need to reach the 10,000 in order for your health to improve. Even increasing from 2,000 to 6,000 can improve health. 10,000 is actually not set in stone. It was a Japanese scientist who came up with that number, but it's a good number to have. And if you have a Fitbit and you have the objective of crossing the 10,000, what it does is when you reach towards the evening and you've only crossed about 7,000 or 8,000, it encourages you to go in for a short walk after dinner to cover the 10,000. So it's not set in stone, but it's a good number to have.
Thank you, Dr. Rajeshri. Final word on HRT for under 60 for all?
For all, no. If they are symptomatic, based on the other risk factors, we need to decide on what to give. For all, no. The answer is no.
Thank you. Thank you. Dr.
Alcohol, no. Alcohol, no. No.
Okay. Thank
Definitely
you.
mixed results are definitely no. Definitely
okay.
no.
Let's put it like this. Alcohol for heart health, no. Definitely not. I think people have started drinking saying it's good for
yes,
them.
Which is why I put this question. So the final word from the cardiologist is the no. Statins are the magic pill. Final word.
Yes, definitely. When the patient has acute coronary syndrome, yes, as a preventive study, it's a magic pill only still because it has pleiotropic effects. Definitely, yes.
Got you. Thank you. Next slide. I think we're done with it. So one take-home message from each of you for our audience, please. Dr. Sheila?
I think lifestyle is probably the most important aspect of menopause and dealing with menopause, because we know that all the lifestyle modalities, whether it's management of stress, having good quality, authentic relationships in your life, having a purpose and meaning, exercising, eating a diet that is appropriate, all of them have an effect on menopause, not just the cardiac health, but generally menopause and the symptoms of menopause. And we know this is also a time where many women go through various other life changes, like their children leaving home, they become empty nesters and so on. So we need to address all of that, which is where the lifestyle management and modification and counseling becomes important. So I think the primary approach to menopause needs to be lifestyle. I know it's tedious, it's time consuming. So have a team like your dietitian, your psychologist, your physiotherapist, etc. on board so that they can also counsel for lifestyle. That would be my advice.
Thank you. Dr. Rajshri, your
As
take home first.
gynecologists, you should take all the window of opportunity to assess for risk, whether it is preconception, whether it is antenatal or postnatal, depending on if they had a GDM, if they had a PIH, initially the BMI, and also perimenopausal transition time. Whenever they come to us, we have to talk to them about the lifestyle measures, explain to the risk and assess the risk at every window of opportunity that is available to us. We should take it as an opportunity.
Yeah. And Dr. Amrita Ganesh, your take home.
2 points. Listen to the symptoms. Clinical is very important. Extensively read about it. Second thing is appropriate investigation and interpretation.
Thank you. Thank you very much. Thank you, Dr. Sheila, Dr. Rajshri, Dr. Arun, Dr. Amrita. Dr. Subhashini couldn't join us, so it's okay. Thank you, each one of you, for making this so much practically pertinent and good take-home messages for practitioners and patients alike. Thank you so much for joining.
Thank you.
Thank you so much.
Thank you.
Thank you so much for the opportunity.
Thank you.
Thank you.
Excellent,
Thank you.
excellent, Dr. Meera and Shanti.
Thank you.
Congratulations. Congrats.
It was a
Thank you.
great panel with all the learned panelists giving us a very good information about all the CVD risk and various scoring systems, Framingham score, calcium score, and Dr. Arun Kumar sir has very clearly put how numbers are very important. At the same time, we should not get stuck or hung up with them, and our motto should be to prevent the progression. And Amrita Ganesh sir was so vocal about so many very important facts. He cleared our doubts very clearly on the various aspects and all the primordial prevention. He very clearly focused. Thank you, sir, for highlighting us about the BP target, how, when, and how to intervene. You have very clearly put it across, sir. Thank you about our Shita ma'am. She was so wonderful, powerful, sleek, and wonderful ma'am has insisted a lot on how important is diet and exercises and sleep, with putting a lot of stress on, especially on meditation and maintaining a proper psychological milieu for every individual, so that it will be so nice that lifestyle intervention like meditation can mold the woman and manage her stress and ultimately her life as such itself. Thank you, Rajeshri ma'am. You were so much wonderful of putting point very clear from the OB-GYN point of view and put things across on women and hormones, especially during this transitional phase of menopause. And wonderful, so great of you moderating, Dr. Meera Raghavan ma'am. It was wonderful. All your questions were really skyrocketing and rocking and very, very useful for our everyday life. Thank you, ma'am. Thank you, everyone. Thank you, Shanti Gunsingh ma'am, for giving me an opportunity. It was a great panel listening to all of you. Thank you all.
Thank you. Thank you. Thank
Yeah.
you. Thank you for the opportunity.
Questions. They asked, one delegate had asked about whether calcitriol, vitamin D, and vitamin K can be given together, or it is calcium citrate which has to be given. What calcium for postmenopausal?
Not everybody needs calcitriol. It's a third or fourth generation treated for osteoporosis. It's always calcium citrate malate for absorption, which is better, and combined with vitamin D and vitamin K2. So that would be a better combination in the prevention of osteopenia and osteoporosis. Calcitriol comes later in the step ladder pattern of treatment of osteoporosis, not as the first.
What about the role of intermittent fasting in metabolic syndrome and all these things?
Intermittent fasting, is it? What was it? What was the question?
Yeah, intermittent fasting and metabolic syndrome and any other role of that.
Yeah, well, it depends upon what you are eating in the feeding window. So intermittent fasting is just a term that separates your feeding window from your fasting window. It doesn't tell you what to eat during the feeding window. And I think that's the important part. So even if you do a 12-hour fast, which is 8 p.m. to 8 a.m., that's good enough for most people, because I don't stress on intermittent fasting. People who can do an intermittent fast can restrict their feeding window to maybe 8 or 10 hours. But more important than that is, what are you eating in that feeding window? It still has to be nutrient dense. It still has to have high fiber, elimination of processed foods, elimination of sugars, and so on. Even though research by Sachin Panda and others have shown that it doesn't matter what you eat in the feeding window, your weight goes down. But we're not just focused on weight. We're also focused on cardiac health, symptoms, and so on and so forth, which is why the importance of what you eat in the feeding window becomes really important. For some people, it's actually easier to do intermittent fasting because, their weight comes off easier. They know that they can eat between 8 p.m. and say 6 p.m. Whereas others find it very difficult to do the thing. So I think it has to be completely individualized.
Yeah, there's another question. Red wine is also not good?
Not good.
The question.
Not good.
Okay.
Shanti, I have a question. Whether vitamin K is available as oral preparation? Vitamin K, Meera, you are stressing on vitamin K. Is it available as oral preparation?
I don't
And
think it is
how to
available
take it?
as
It comes even in certain combinations, madam.
Yes, nowadays.
In certain calcium combinations, the
they have introduced
vitamin K2.
Yes,
K3,
menaquinone,
I think, is available.
K2, K3 is available now as combination.
Yeah.
As such, you don't get a K2 tablet.
But it's available
combination.
calcium, vitamin D, and K2, madam.
Yeah, to avoid this calcium paradox, I think it has been emphasized to do this.
Okay.
Yes,
okay. Thank you.
Now, can we go, Sakiti?
Yes, ma'am.
Quickly display the results. Yeah.
Our,
So question number 1, the answer is early menopause as the correct answer. So which increases risk of cardiovascular is question early menopause. Which is true? Next slide, please. Which is true? Increased central adiposity is associated with an increased risk of mortality, even if they are normal BMI. So it's basically truncal obesity, which is associated with increased CVD risk. The second question, answer is 1. Next, please. Defines premature ASCVD, which is men less than 55 years and women less than 65 years. Thank you. Next slide. Which of the statement is true? Diabetes is a greater risk factor for heart disease in women than in men, which it's truly so. So that is the first correct answer. Women compared to men are more likely to have atypical symptoms and less likely to get appropriate guideline-based therapy, which is why we need to look into those promptly. So these are the answers for the quiz, which was done interim. Thank you for participating.
We have had a lot of participants and 4 have got 4 out of 5 correct. And Dr. Purvi Loganathan, Dr. Sumati Anand from Madurai, Dr. Keetika from Madurai, and Dr. Rohini from Chennai got 4 out of 5. And Dr. Purvi Loganathan stands first and Dr. Sumati Anand second. Congratulations, winners. And it's nice to have a state level reach in our webinars so that more menopausal women and we also benefit. Thank you very much.
Thank you, ma'am.
Dr. Anjulakshmi ma'am, can we quickly post the vote
So
of thanks?
good evening, everyone. I have the pleasant job of giving the vote of thanks. First of all, I want to congratulate Dr. Shanti Gunasingh and Dr. Meera Raghavan for this wonderful CME. Okay, and my sincere thanks to these excellent speakers, Dr. Ganesh and Dr. Arun, and a brilliant panel discussion moderated by the brilliant Meera Raghavan and a challenging panelist who answered very well. And on the whole, the whole CME was with a lot of learning points for every one of us. So once again, I thank all the participants, not only the speakers and faculties, and also the delegates. They have all, I think everyone will be benefited by this wonderful CME. Thank you very much.
Yeah, and I'm very thankful to Dr. Anju Soni, who was present.
I left behind. So the chief guest and the guest of honor, yes.
Our own beloved guest of honor, Dr. Revati, and the three chairpersons from different places of the different areas of the state. And I have to thank Sahiti Priya for really coordinate from Shield Healthcare for really coordinating the program very well. And we are always thankful to Shield for having given us the platform. So thanks a lot.
Thank you.
Thank you, ma'am.
Thank you, Shanti, for
Thank you.